Now, Lord Clerk, we'll ask you to take the oath. Mary will take you through the oath.
I gather you don't want me to stand for the oath.
You can stand or sit as you please.
Most people sit, that's fine.
Most people stay sitting, right.
Please state your full name.
My full name is Kenneth Harry Clarke.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence that I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Lord Clarke, I'm going to start by asking you a handful of questions about your parliamentary career. You became, I think, an MP in 1970 and remained an MP until November 2019.
Correct.
Now, you've held a number of government positions, but the two in which the inquiry is interested are your tenure in the Department of Health. You were Minister of Health in the Department of Health and Social Services, as it was then called, from the 5th of March...
Health and Social Security.
Social Security. 5th of March 1982 to the 1st of September 1985.
Yes, if you look that up.
And then you were Secretary of State for Health in what was then became very rapidly the Department of Health, separate from Social Security.
Well, it was. I was sent there when it became, when the two halves, quite distinct halves, of the old DHSS were separated. They'd really always had operated as two separate departments. So I was the first Secretary of State for Health at the Department of Health.
And that was from the 25th of July 1988 to the 1st of November 1990.
If you tell me so, sounds right.
And both those posts were in the government of Margaret Thatcher.
Yes.
Now, you've held a number of other ministerial positions. You've listed those in your statement, and I'm not going to go through those. You became a peer in September 2020.
Yes.
But before I ask you about any of the substantive issues, can I ask you this? Have you signed the Official Secrets Act? And if so, does that inhibit or restrict the answers you give?
I think I have signed the Official Secret Act many years ago in one of my government posts. Yes, so I probably have. I obey the Official Secrets Act anyway.
But does that restrict or inhibit or prevent you from answering any of the inquiry's questions?
No, not on blood products. No.
Now, I'm going to concentrate today on the period of time that you spent as Minister for Health, 1982 to 1985. And just so that we can understand who the ministers were in the whole department, as you've indicated, the department at that time was responsible for both health and social security. And the Secretary of State, the top of the ministerial hierarchy, was Norman Fowler, now Lord Fowler.
Yeah, and he was the only one who bridged the two. It was a very odd combination. I think they were just regarded as part of the welfare state, but actually the health ministers had nothing whatever to do with pensions, benefits, and all the rest of it, and the social security ministers had nothing whatever to do with the National Health Service, community care, and all the rest of it. Norman presided over both and was the cabinet minister and the head of the whole thing, but they had two really quite separate chains and quite separate teams of officials working below him.
And then in terms of the health side, you were, as it were, the next one down in the ministerial hierarchy.
There's three ranks of minister. Secretary of State, usually cabinet level, top of the head man with overall responsibility for everything. Then Minister of State, which is a kind of, Sergeant Major or something. You're the next rank up, but you have a kind of wide range, but you have specific responsibilities. And then the Parliamentary Under Secretary of State is the most junior rank. Each of the three, in practice, tends to concentrate, particularly the junior ministers, and the junior ministers are the Minister of State and the Parley Sec. They tend to concentrate on particular aspects of what is the most enormous activity, the National Health Service and social care and local authority social care. You all have to concentrate on doing particular bits. Minister of State, I was the nearest to having an all-embracing thing because health service is permanently controversial. And there's always crises over, I spent my time in hospital closures in those days, pay claims, all this kind of thing. But even then, you and the Parlysec's divided up and have your own bit.
And then the parliamentary Under-Secretaries of State for Health during this period, there was one in the Commons, who was Geoffrey Finsberg and then John Patton, and then one in the House of Lords, and that appears to have changed, I think, 4 times over the period you were Minister. Lord Elton, Lord Trefgain, Lord Glenarthur.
Lord Trefgarne.
Lord Trefgarne, my apologies. Lord Glenarthur and Baroness Trumpington.
Well, there were more, and Gloria Hooper was there, Baroness Hooper, because she took, Baroness Hooper, what I remember best, because she took the very controversial health reforms, the legislation for my health reforms, which was my main activity when I was Secretary of State, through the House of Lords. So don't leave out Gloria Hooper. But I don't think Gloria Hooper had anything to do with blood products.
I'm just concentrating for the moment on those who occupied the positions in 82 to 85. We'll come on tomorrow to look at
I'm sorry. Yes, I've got the wrong dates. My apologies.
Now, you explained in your statement that the areas of responsibility for which you had primary ministerial responsibility did not include matters of blood policy, blood and blood products. And we've heard from Lord Glenarthur that was one of the areas allocated to him. What were your areas of responsibility as Minister of State for Health?
They were, overall, the political role vis-à-vis the National Health Service as a whole. Now, the 1980s, the National Health Service is the biggest business-like activity in Western Europe, the biggest employer in Western Europe. It is the centre always, or has been ever since it was founded, of political controversy, usually crisis. In the 1980s, industrial relations played a huge part if you were a minister dealing with any public service or any nationalised industry. So pay claims, strikes, the threat of strikes, actually, to an astonishing degree, dominated not only, the purporting of politics, but far too much time. And of course, we were having an extremely controversial battle as a government to try to sort that out in the Thatcher government. The other things that caused fantastic controversy, in which were mine, were hospital closures, building of new hospitals. The building of new hospitals were always opposed because of planning and because the bus routes weren't right. The closure of any hospital, even a disgraceful Victorian ruin, was a matter of wild controversy. The service was run, attempted to be run, by a centralised bureaucracy in the health service with thousands of officials who couldn't actually get themselves involved in everything from Wakefield to Truro as controversy came up. We did have health authorities, and you had to try to work with them. 15 regional health authorities, whom I met the chair quite regularly. They were very helpful, actually. They were a good way of pulling it all together. I can't remember how many district health authorities. They varied enormously in quality. Some were very political. Some were quite hopeless. Some were extremely good and didn't trouble you at all. They always complained they were short of money. The health service has complained it's short of money ever since 1948, although the budget of the National Health Service has never been cut in any year in real terms by any government since it was founded. It's always gone up, but no one would ever know that because large parts of it run out of money. I'm giving you some idea. Now, I was involved in most of that. And that included me in a lot of politics, because then I have to then present that to the House of Commons. I spent half my life on the media because we were often in the middle of controversy. Both my stints at Health, I reckon I did the Today programme on the radio about twice a week, and so on. Now that was, I actually was more involved in all that, and I had policies I put into that. I made the controversies worse by, I had a policy of getting rid of the old Victorian asylums, getting rid of the old geriatric hospitals, which was a name they'd given to some of the old workhouses, which were a scandalous disgrace in which people were kept in appalling conditions. But there was a tremendous fight about closing them down. They were centres of clinical excellence. I won't carry you any more details, but that was my daily life in the Department of Health. And blood products was something that hardly ever came across my desk. I mean, obviously, as the tragedy with the haemophiliacs began to develop, I was aware it was there. And as you know, I'd from time to time, usually at my own instigation, got on the edge of it. But I didn't call meetings on. I was never the minister directly responsible for blood products. I was never asked to take a decision on blood products. I never intervened to take a decision on blood products. And I did intervene or get involved in discussions a bit when I wanted to be reassured. I was a bit concerned. Or Simon Glenarthur wanted to touch base with me as I was aware it was going on. But just to give an example, I was greeted when I arrived. When I arrived as Minister of State, within 4 days, the entire National Health Service went on strike. It's the only national strike the Health Service has ever had. I mean, only in militant areas did it have a big effect because the staff of the Health Service won't go on strike. So it was only in London and Liverpool that things were quite grave. It became the longest public sector strike since the war, I think. So we went on for several months until we eventually resolved it. And I was the principal firefighter and involved in that, visiting hospitals. I got caught up in picket lines sometimes, and that was just a theme that, as I was getting used to the office, ran across all my things. I give you all this long answer. I'll try to make them shorter in future. Blood products, I was never directly responsible, unless someone pointed out to me that something was going on so far as the blood transfusion service or blood products. I had nothing to do with it, and that was true for most of my time in the Department of Health. The campaigners attributed everything to me because I later became a well-known figure.
Well, we'll come back to some of those issues, Lord Clarke.
That I was not involved in it, not directly.
How as a matter of organisation or allocation, how was it decided that blood products would be the responsibility of, say, Lord Glenarthur, rather than...
I imagine someone would put a submission to some Secretary of State. I don't know. I didn't decide that anyway. That's before I arrived.
So would the allocation of responsibilities ultimately be a matter for the Secretary of State?
He'd be the one who could change it, and they probably might change it if the permanent secretary or somebody suggested to him. I don't know. You must, if you're calling Norman, ask Norman whether it were. But when I was Secretary of State, because I eventually, my second stint, I know we're not talking about it now, but so just deal with this point. The only thing, I didn't change any of the responsibilities. They were, as ministers changed, they inherited what their predecessor had done, and I suspect that had gone on for a long time. The only responsibility I got concerned about was who was going to do the legislation in the House of Lords, because I knew I was going to have a major and controversial piece of legislation, and I wanted to have some feeling as to who was going to do that. Hence I mentioned Baroness Hooper, who actually did it.
Did you, as Minister of State, have general responsibility for or some degree of oversight of the decisions taken or not taken by the more junior ministers?
No, not normally.
Do you know which minister, if any, was responsible for the work of the licensing functions carried out by the Medicines Division of the department?
No, but ministerial responsibility doesn't amount to much. The one thing ministers do not, ministers don't interfere with the regulation of medicines and the licensing of medicines. And the ministers are not clinicians. None of them, in my day, none of us had any clinical qualifications at all. You're not expected to be an amateur doctor because you're a minister in the Department of Health. those authorities are completely free of ministerial interference. So, apart from pay and rations, if there's some argument about their budget for the year, no minister would have anything to do with the decisions of the Safety of Medicines Committee or the licensing and so on. Of course, we had a whole lot of medics. The chief medical officer and his deputy medical officer and the medical officers, they were the department's people. The chief medical officer really was the person in charge of all the medical things. And when issues were clinical or scientific, or they touched on the treatment of patients, they would be heavily involved. The chief medical officer was able to draw, of course, on the advice of the medical profession as a whole and get in. They always set up ad hoc committees of specialists in particular things to advise them, and then they give advice to ministers to make clear that the ministers understand the clinical and scientific position. Ministers don't second guess the medical. If you had some minister who'd got some pet theories about health and started suggesting an alternative treatment, one would rapidly get him removed to another department because that's not the job of a minister, and the medical profession would get very, very worked up. They did get worked up about clinical independence. In the end, the doctor-patient relationship is such that in the end it is the doctor treating the patient who's entitled to make his or her decision about the treatment of that patient with the consent of the patient. The idea that a minister's got anything to do with that, complete nonsense.
Well, we'll come back to some of those issues.
And the key people in the haemophilia thing were obviously the haemophilia specialists, who were a very specialist group of medicines themselves. The average general medic would have been very cautious to give a view about the treatment and care of haemophilia.
We'll come back to some of those issues, Lord Clarke. Again, just dealing with some matters of general responsibility. Did as Minister of State for Health in the Department of Health and Social Security, what was the geographical reach of the department? Did it cover just England and Wales? England. Your recollection is just England?
My recollection is England. I mean, we didn't have, full devolution hadn't taken place, but I think the health service was always pretty devolved.
Do you recall any particular interactions with or measures for liaising with the Welsh office, Northern Ireland office or Scottish office? Well,
the first time I mentioned it today, I remember you're asking me about events almost 40 years ago. So I may have forgotten some incident. If you prompted me about some contact I had with Scotland or Wales, and I don't actually remember at any stage having any dealings whatever with the Welsh office, the Scottish office, or the Northern Ireland government.
Do you have any recollection of whether the general understanding was that Scotland, Wales, Northern Ireland, either cumulatively or individually, would follow England's line, or was it was your recollection?
I really don't know. I've never involved. I don't know any contact, and I don't know. The devolution wasn't such a big issue then. I just can't remember. I assume because we were all members of the same government. I mean, the Scottish office ministers and the Welsh office ministers and were colleagues of mine in the government. But I think. I don't think we did wildly different things, but we were run separately.
If we just look at one passage in your witness statement, Lord Clarke, Shomik, it's WITN 0758001.
Do you know what page that is?
Yes, I'll find the page, Lord Clarke. It's page 9, paragraph 2.1.
Thank you.
Page 9, please, Shomik. 9. You don't have a page 9.
Page 9, yes, I found it. Paragraph 2.
2.1.
2.1.
So if you could forgive me for a moment, Lord Clarke, we don't seem to have it electronically available. It doesn't matter. You've got it, and there's only one sentence I want to ask you about, so I'll read it out. You say in the third line, the inquiry will be aware that at the time, the DHSS was responsible in England for the administration of the National Health Service. In addition, it was responsible for the social services provided by local authorities to the vulnerable in society and for some aspects of public health. Can you recall what aspects of public health fell to the department, or what other bodies were involved with public health?
I can't remember. I mean, the Department of Health always had a role in advising people, putting out separate running campaigns occasionally. Sir Donald Atchison, who became a chief medical officer for a high proportion of the time, he was particularly keen. He was, before his time now, it's much more popular now, on disease prevention, health education, as well as being a highly conscientious man on treatment. And so the department did run some campaigns, probably in those days, trying to get people to give up smoking, trying to get people to take more exercise, and so on. And so that's what I think is. This is a description taken from some formal description of the role. That's the sort of thing the Department of Health does. And then, of course, there's constant interaction between the medical profession and the pharmacists and the dentists and the GPs and everything else with the department, because they have to interact all the time, because we were administering them, and that included public health messages. The CMO would somehow, I think, he wouldn't put it to ministers, nothing to do with ministers, but he would put out newsletters to doctors and so on, and take part in the discussion, but it wouldn't intervene in the treatment of patients, but it would take part. That is the kind of thing the Department of Health did. In neither of my stints at the department did I have very much to do with that at all, certainly not as Minister of State. Secretary of State I did. We had a health education authority by then, and I usually deal with them occasionally, usually when they were trying to persuade me to allow them to run some fresh campaign. But the campaign would be their idea, and they'd occasionally to try and get to help them.
If you turn to page 14 of your statement, Chairman, I don't know if we have that right. Paragraph 2.22. You've referred in paragraph 2.22 to the Griffiths report, which was a report commissioned to look, as I understand it, at the management of the National Health Service in 1983. And you say this in the third line: the idea in relation to the latter, that was the establishment of a management board, was to remove the DHSS from the more day-to-day running of the National Health Service. And then you go on to explain how the management board was established in April 1985. You refer also to the establishment of the Health Services Supervisory Board. Would it be right to understand, in very broad terms, that as at 1983 and before the reforms recommended by the Griffiths report were implemented, that the department did have quite an active role in the day-to-day running of the NHS?
Well, it tried to. What happened was, every time anything went wrong locally, the Department of Health was blamed, and it was politicised. So the department felt it had to get involved, and the Department of Health spent its time trying to sort them all out. You may know there's a famous phrase from Nye Bevan, because he was the first one who created a service where he was in the middle of constant controversy, as every Secretary of State for Health always regarded as in crisis by the general public. And he once made a remark, I can't remember exactly, but he found he made himself responsible every time someone dropped a bedpan in Rhondda. I think he being Welsh, he collected a Welsh example. He personally was held responsible. It ran in this rather chaotic way. The other problem, which I won't burden you with, is that there's been an attempt to reform the management locally of the service by Keith Joseph in the early 70s. And we produced a form of management which was called collective management. There was no one in charge in any hospital. There were officers, all of whom were equal ranking. It had been an idea of McKinsey's, which Keith had taken up. It did not work. Roy Griffiths, in his report, came out again with what came at the time a well-known quote, that if Florence Nightingale came back today and went to the nearest hospital and asked who was in charge, nobody would be able to give her an answer. When you talk about the Griffiths reforms, Margaret had got Roy Griffiths to come in to do this. He came up with a very good analysis of the problem, and we had these new institutions, but they didn't really make a difference. The reforms were what I turned up to do when I went back as Secretary of State for Health, and they involved much more devolution of responsibility, so long as they're accountable upwards, much more competition and choice when spending the money, where you spent it. I was determined to concentrate on the outcome for patients, value for money, getting the biggest bang in terms of patients cured and treated for the ever-increasing amounts of money we were putting in. I was to get away from this bureaucratic shambles of squabbling all the time, the dominance of industrial relations and the politicization of everything. But the day-to-day running, I did try to stop it being done by the officials in the Department of Health in London, because it was a shambolic bureaucracy. And the controversies about it in the 1980s had reached a new peak, which is why Margaret got Roy Griffiths in, why she eventually declared she was going to reform it, and why eventually I wound up producing the reforms, because it could not have gone on as it was. It can only be described as, I mean, the officials, some of them were very good, they did their best, but the whole setup, the structure, was a completely shambolic bureaucracy, which is why blood products, which was a comparatively calm area until it had this horrendous problem that took us all by surprise when a new disease and new infection started emerging, was a quiet little part of all this. It was very big because of the tragedy now, big this inquiry, but the reason, when I arrived in 1983, the idea that blood products was a very, big part of the department's activity is just simply not true. It was a very specialist, usually quiet, harmless subject, one of the few areas where we didn't have controversy, and there wasn't very much for the department to do because the blood transfusion service ran itself.
Just again in general terms, and looking at this first half of the 80s, can I just explore with you various ways in which the department might exert some degree of influence over decisions of regional health authorities, NHS bodies, clinicians in general? One of the ways in which the department could exert influence presumably would be through its funding decisions, the amount of money it made available.
Would be what, sorry?
Through funding, the amount of money it made available to regional health authorities.
Well, the allocation of the funding was it dominated our lives, because, it's still true, I mean, it's true today. The health debate, as far as the public are concerned, is always about money. The party which is in opposition, their policy on health is always, it's short of money and we'll spend more money. And the party of government, their policy is always, it's never had so much money as it's had before, we put more money in last year, we will carry on putting money in. Of course, money is just the background. It's far more complicated than that in every area. What we tried to do was to allocate the money to the health authorities according to the needs, the respective needs. And again, I was more anxious in terms of patient care and then trying to hold them to account for the outcomes. But the allocation of money was done, therefore you'd get some sort of formula to negotiate sometimes, the department would negotiate, but we allocated money on what we thought was a fair distribution between the regions and through them to the districts. What happened was that the control of money in the whole service was pretty useless. They couldn't usually tell you how much anything costs they were spending money on. And as you approach the end of every financial year, because we'd started enforcing budgets and cash limits, which had been even more chaotic before Margaret's day, The ones that had got spare money and found they hadn't spent their allocation would run around the hospitals asking anybody want to buy any kit for next year, anybody got the thing they want to spend some money on, and they get rid of it. The ones that ran out of money at about Christmas and so on would go to the newspapers and say that the cuts were causing them terrible harm and they needed more money and so on, and they were the ones the minister usually had to deal with. Sometimes you did have to bail them out. But that is, that is the relationship, I think, is about as clear a description I give. And if it sounds a little strange and shambolic, as I said before, if you want to go for broader health policy, it was very shambolic in the 80s. Had it not been for HIV and hepatitis, the blood transfusion service would have been an oasis of non-controversial calm. Hence, it was one of the ministerial duties of one of the parliamentary under Secretary of State, usually in the Lords.
As well as providing funding, the department could also influence regional health authorities by, I think nominally in the name of the Secretary of State, issuing directions or instructions, could it not?
Yeah, I had regular meetings. I began to try and get some order in it, because I had to work out how I was going to, not just defend the government, defend myself, but actually influence this and in some way and make some sense of it. And I had regular meetings with the Regional Health Authority chairman, and they became quite crucial to my relationship. They gave me some order. I actually, in appointments, tried to get some people in. I tended to appoint local businessmen with some business experience, and not particularly political people. We didn't want local authority politicians or trades union people, chairmen of health authorities. What I wanted was someone who had the motivation of wanting to serve a great public service, also had some experience of the managerial decision-making in a giant and complex organization, or actually, or sometimes medium-sized firms. And I had regular meetings with them. I got on very friendly terms with them. They were my best way of influencing the system through them. I used to joke with them occasionally. Several of them in later years became personal friends. They were my cabinet. I could get some order and stop dealing with the District Health Authority in Wakefield through the columns of The Guardian, if the actual Yorkshire Regional Health Authority chairman also got his hands on it and tried to find out what the devil they were up to in Wakefield and why they got themselves into this mess. But
so you could influence...
my answer's a little, chaotic and all the rest of it. It was a chaotic world, the NHS in those days.
So you could influence potentially, and I'm talking in general terms here, I'm not talking currently specifically about matters relating to blood policy. You could influence regional health authorities through the process of meeting, collaboration, information sharing.
With the chairman.
But was it also open to the department, if it thought it appropriate to do so, to issue instructions or directions?
I don't think so. I don't remember ever issuing instructions or directions. You might have done some to recalcitrant district health authority.
It was also open, was it not, to the department, or possibly here through the Chief Medical Officer, to issue guidance to clinicians, dear doctor letters, leaflets? And
I think the Chief Medical Officer, my recollection is mainly Donald Atchison, who was much more active than his predecessor. But I think Chief Medical Officers generally do issue guidance and so on, but he'd do that of his own bat. He wouldn't consult ministers about that. And the Chief Medical Officer would be the medical scientific issues of the day and the advance, scientific advance, that would be entirely the Chief Medical Officer. And they'd make sure that there was no gap. There was a rule, a tradition, a convention in the Department of Health in those days, may still be. Every time the minister, including the Minister of State or the Secretary of State, had a meeting, by which what we call by a meeting is a whole lot of half a dozen maybe 7 or 8, perhaps 2 or 3 policy officials where you're talking through and deciding something and getting briefed and all the rest of it. Every meeting had to have a medical officer at it, so that the non-clinicians, the ministers and the lay civil servants, didn't start wandering off doing odd things because they didn't understand the medicine and the science. So there would be a medical officer every meeting I ever had as Minister of State. Now the medical officer would work to the chief medical officer. They would do all this stuff about newsletters and making sure that doctors were up to date in what was happening, although doctors them usually keep up to date through their own professional bodies and through the medical journals, which any responsible GP and surgeon does his best to keep up to date with the constantly changing pace of medical advance.
And then the department could also put information into the public domain, could it not? Whether through press releases or through the more formal process of speaking in Parliament and answering parliamentary questions?
Well, you can make statements, but they were usually statements on government policy. I mean, the ministers are politicians and members of the government. So the ministerial role is not medical, clinical. It's not giving of the minister's job is not to go around giving health advice to the public at large. The minister is the person responsible for financing, decision-making, delivery of the health service, and its presentation in Parliament, accountability to Parliament, and handling the wider, in case of health, constant public controversy. Every Secretary of State Health always finds that he or she is the most controversial member of the government of the day. It's inevitable. I always warn my successors, for heaven's sake, don't think you're going to become popular when you're Secretary of State for Health. No Secretary of State ever has. You're in the middle of the constant presentation of your political role, your executive role, as the government minister in overall charge of it. The CMO is in charge of all the medical scientific stuff.
You have described, in the inquiry heard described last week, a parallel hierarchy within the Department of Health of the medical officers reporting ultimately to the Chief Medical Officer, and then the administrators reporting ultimately to the highest, the Permanent Secretary.
The Permanent Secretary.
Within the department. One of the medical officers from whom the inquiry heard last week, Dr. Wolford, who subsequently became a Deputy Chief Medical Officer and later on, was critical of that division. She suggested to the inquiry it was outdated. I think she used the phrase in her statement, the expert on tap but not on top.
The what, sorry?
The expert on tap but not on top.
She thought the medical officer should have a bigger role.
Well, I think she was critical of there being this parallel hierarchy rather than there being, I think, more interwoven. Do you have any reflections on that?
I hadn't heard it, but I've not really addressed the issue before. I have a lot of time for Diana Wolford. I mean, I haven't met her since I left the department, or I don't think, but I'm sure if you showed me a photograph, I'd recognise her. The name is very familiar. And she was one of the medics who obviously advised me, but I don't know what change she was proposing. What you couldn't have was the bureaucracy of the lay civil service taking medical or scientific decisions, and the medical officers were, on the whole, we had a good lot. The first chief medical officer I had, not very good, but Donald Atchison was a splendid man, saint-like man, but a very hard-working man. And Diana Wolford, I seem to recall, was one of the ones I particularly trusted and liked with her advice. I mean, I didn't realise it was that strict, the division. I just, we all worked together. I hadn't realised there was any tensions between them. Don't think so. I'm slightly muttering away, but you're asking me a question of structure I'd never even thought about before. I didn't know she was critical of it.
You say in your statement that you didn't have, I think you and your colleagues, rather than you solely, didn't have the requisite clinical expertise to go behind the expert advice provided by the Chief Medical Officer and his team. that reposes an awful lot of trust, does it not, in the reliability and comprehensiveness of the advice you're receiving?
Yeah, you did, which is why you had to have confidence in them. And I mean, don't get me wrong. All the advice I've ever received from anybody, whether a civil servant or thing, the duty of a minister is to challenge people. I mean, if the advice surprised you, if an interventionist medical officer, I certainly, my style will be really the case, good grief, surely not, and so on. And if the Diana Walford or Donald Atchison give me opinion, I will often debate it with them, and they would explain to me if I got the wrong end of the stick, why they were giving that advice. But once we got Donald Atchison in, I thought, in fact, as it happens, the medical officers were amongst the higher quality people in the place. And what you couldn't do was start sitting there. I don't personally sit there and argue with my GP, and treat him on medical. I don't start challenging his medical opinion. You can't start. I have no clinical expertise whatever, so you are relying on them. You have to trust them, but it isn't just them, of course, because they have to relate with the medical profession as a whole. So it's relevant to this inquiry. If you have a totally new disease, when HIV/AIDS emerged, about which nobody knows everything and which causes panic because it appears to be fatal, there's no cure, and so on. I mean, they're heavily reliant on all the contacts they've got with the colleges of medicine, the specialists on the ground, and they themselves draw in. And what the CMO always does is, when we've got anything like this, because it's always, at the moment we've got COVID, you set up all kinds of expert advisory committees from outside. The CMO sets up all kinds of expert advisory committees of the people who are experts in this particular field where the problem has now arisen, so that his and his team's advice to ministers on the science is informed by getting all the experts.
So in general terms, you would expect, and indeed to some extent rely on this happening, you'd expect the medical officers to be drawing on the widest available relevant expertise.
I'm sure they did, yes.
Particularly in relation to something that's uncertain and new. Absolutely.
And when the question arose of HIV in haemophiliacs, which is what we're actually dealing with here, I'm sure that I'd be amazed if Diana Walford would have told you that they would be in contact with the people who knew most about it, which is the haematology specialists and the people who did specialise in the day-to-day treatment of haemophilia, who had been, they're the ones that had started using this amazing new treatment, factor 8. Well, that was a decision by doctors who specialised in haemophilia. And then when we started getting worried about the factor 8, I imagine that our medical officers spent a great deal of time dealing with them. And I don't know, you would know, I don't know, but Donald probably did set up a little committee, didn't he, of haemophilia experts.
We'll come on to the committees and expert groups that were set up. But broadly speaking, if you have something like a new virus, would you expect your medical officers to be going not just to haemophilia clinicians to consider how it might impact haemophilia treatment, but virologists, epidemiologists, public health experts, to draw on all different areas of expertise?
Well, only one to look is easier, less problems of memory. There are a lot of comparisons to be drawn with COVID. We've got a really major national pandemic at the moment, but it's all the same parallels, completely unknown new disease that nobody knew anything about. And so all of us, everybody in this room, is familiar with talking about committees like SAGE, which is in our newspapers every day. Well, that is an expert group, I think, that's been brought together, assembled. I'm sure the lead's been taken by the chief medical officer of the day in doing that. and a range of virologists and experts, people with some, and others, and there are some psychiatrists and behavioural scientists and all this sort of thing, a team of people, but drawn particularly because they're leading specialists in the relevant branches of medicine for finding out something about this new disease and how we should react to it. Now, exactly the same thing would have been done in the case of HIV/AIDS. And then, when we had a subplot of HIV/AIDS, because we had this particular problem with haemophilia, hematologists would be brought in as well. I mean, I say this, I think it would be done, but I just assume it was done. But it would be the chief medical officer who I would expect to do that.
So you're describing what should have been done in any event?
Yeah, and I think was, wasn't it?
Well, not for me to answer.
Well, they should. I'm not the right person to ask. You presumably asked Diana Walford.
Indeed.
She told you what the setup was. I think, I discovered from the papers. I didn't know it before. She was a haematology specialist herself, which was a bit of good fortune that we got somebody in our own team who had a part of her career being a specialist in haematology.
Now, you've referred to Donald Aitchison, who I think became CMO in around October of 1983. So for the first...
Sorry, who was this?
Sir Donald Aitchison, Dr. Donald Aitchison.
Yes.
Or Aitchison. For the first 18 months or so then of your tenure as Minister, the Chief Medical Officer was Sir Henry Yellowlees. Did you have many interactions or any system of meetings with him?
There was Henry Yellowlees. I did first. Not a lot. Henry Yellowlees didn't immerse himself in these medical issues very much. Henry Yellowlees somehow, perhaps we just didn't hit it off. But I don't want to say I'll upset his family if I say unkind things about Henry Yellowlees. But he didn't actually give much clinical advice to me. He didn't immerse himself in things. It was much better to deal with members of his team. I can't remember, obviously 40 years ago, I can't remember individual meetings or events, but had something come up about haematology, I would have found myself dealing with Diana Walford, not with Henry Yellowlees. And it was a huge improvement when we got Donald Aitchison in. Donald Aitchison was a conscientious, really serious, committed figure who immersed himself in what I think were the responsibilities of the Chief Medical Officer, and it would give me advice I'd expect from a Chief Medical Officer, and it was advice which I could have confidence, I always thought.
Again, in general terms, I want to get an understanding of how information might reach you as Minister. So the guardian, as it were, of the Minister is the Minister's private office. And so information would be provided by administrators or medical officers to your private office and then to you.
Every part of the department would pour papers upwards into the ministerial team. Usually, obviously, whichever minister was responsible for whatever they were doing. The Secretary of State's office got a very high proportion of the lot, because when I was Minister of State, I would only get the things I was doing, and vast amounts of paper would pour in. When you're talking about paper, bear in mind we've also got ministerial correspondence, which was building up in the 1980s. It's even more, I'm sure, now. Thank God we didn't have emails. But you get hundreds of letters would come in every day from members of the public and various other things. You've got all the parliamentary questions, large numbers of written parliamentary questions and so on. So unbelievable quantities of paper will be pouring in to the private office of ministers, and when I was Minister of State, but an awful lot of health service paper would come in. I had a private office of young, keen, rising civil servants, about half a dozen of them. One of them, though, probably the full-time job was sorting all this paper out, and the key role that the private office had to play was deciding which of this should the minister see, which must he see because he ought to see it, what would he want to see, because it really is relevant to things he would want to get engaged in, and so on, and watch. And they would try to, they would cope with all this paper and get down to producing those papers which were going to be put in front of the minister, either physically on his desk or in the red boxes in the evening, for him to do when he got home and come back with in the morning with his scribble all over them and his response to it, and in order to make it manageable. And everything else will be dealt with, officially, and that is the main source of information. Now, otherwise, you have what we then do. I would respond with issues. You'd respond probably to the papers. I would ask for a meeting. Then the next civil service process would be the meeting, where a collection of officials would come in, dealing with the thing the minister now wanted to talk about. You'd start with the paperwork would be the basis you were working on, but then you'd have a general discussion. I like general discussions. I like challenging views. And so competing views, we talk it through, and 9 times out of 10 we come to a rough consensus at the end. The minister would have to take the final decision, but I personally would change my mind sometimes. I'd have some bee in my bonnet and be quite rapidly be put right by some official who'd realise I got the wrong end of the stick and so on. And then that way you come to a settled, informed decision. Minister take a decision, and if it involved initiating action, right. As I would, minister state, I wouldn't do it like this, didn't use these words, but that was what the minister decided. That's what we decided was the conclusion of the meeting, and then the machine is meant to go out, put that decision into practice.
We'll explore during the course of your evidence various matters that did get to you as minister and others that did not. Was there any guidance or yardstick as to what kind of issue did have to go to the minister and what kind of issue could left to be resolved by civil service?
No, there was any formal guidance. We had enough, for heaven's sake, we don't want more bureaucratic rules. In the end, it's a matter of judgment and common sense. It's usually fairly obvious that the minister is going to be involved in this. When some newspapers had come in about a strike that broke out somewhere, you'd raise your eyebrows and say, blimey, the minister better see this soon at the end of his next meeting. He'll want to know this has happened. Other things, we better get involved in this a bit and find out what's going on, and the minister might want to find out what's going on and so on. It requires judgment and common sense.
In general, when a minister in a department like the Department of Health took up their new post, what was the system for attempting to bring the minister up to speed with issues that fell within their areas of responsibility?
You'll be presented with huge piles of briefing. So you better settle down for a couple of days of intense reading, and then there'll start to be some meetings so they can start briefing you. It should be your way of meeting the people you were going to work with, the senior officials who likely to be coming to you, having meetings, different things, and you'd be immersed for the first week or two. A big department like this, you briefings and paper and so on, try to get you up to speed. You had to be very cautious. It's a sort of in those days, no one ever gave any training. Every minister taught himself how to be a minister, or herself how to be a minister. You were just plunged in. The first job I was ever given, I didn't even know where the department was. I had to find my way there. And as someone who'd never been involved in this kind of thing before, found I was being immersed in this thing of firstly huge piles of paper that I got to read on the subject, and then all these things. And as I became a sort of old veteran, and I don't usually go around giving boring old veterans advice, but I used to make a joke saying, just be careful what you do in the first month or two, because you will find your responsibilities are so massive that it take a couple of months before you really take a key decision, because you may regret it. And certainly don't, if you think it's a department don't sail in with pet ideas, instantly start implementing them, try them out, test them, use the opportunity to get in-depth knowledge of the subject, because politics is always conducted in terms of simple solutions, polarized opinions. Most government decisions are complicated, multifaceted, and you need to immerse yourself. In fact, I used to say that until you've been there a couple of years, you won't really understand it. Then you'll be an expert. You'll have real ideas of what you wish to do. Then you'll find the Prime Minister reshuffles you and you have to start all over again. Fortunately, one of the reasons I look back with pleasure on my time at Health was the 2 stints meant that I was there for so long. By the time I left as Secretary of State, I was confident I knew exactly what I was doing, and it was my agenda. I was putting in place the things I thought were in the public interest. I thought were going to strengthen the health service, supported, fortified by all the briefing, discussions, arguments, everything else I'd had with my officials.
Was there any practice or system of regular ministerial meetings? Would you?
We used to have a weekly meeting, I think. I liked to, in all departments I was in when I was in charge of them, the later ones. You'd keep in touch, but you were also busy. Sometimes you'd see remarkably little of most of your colleagues.
Would those regular meetings be minuted?
I know that they were usually. I don't know, but I mean, a private secretary would sit. A private secretary would sit in and practically every time you met anybody, but wouldn't always minute it. They were just a way of touching base, and it was, you know, they weren't formal. They were how are you getting on? You're having a bit of trouble, aren't you? You know, or Virginia with whatever it is, and you just kept in touch and then shared with your colleagues things which were causing you a particular problem. If you wanted to ask your colleagues, what do you think about all this? I'm having this particular row at the moment about this. What do you reckon I should do? They were that sort of meeting, just to make sure colleagues touch base with each other. I suppose the Minister of State and the Parliamentary Under Secretary of State for Health, they'd see each other quite a bit. There'd quite often be meetings where we'd hold joint meetings and we'd both be there in subjects which really cut across both our desks.
In terms of documents, we'll see as we go through some of the specific issues in which you became involved. There are documents, sometimes briefings, sometimes other documents that are no longer present, have not been found.
I'm sure there are.
I understand in relation to your private office papers, you had a particular way of marking the material that came to you.
I had a habit of underlining key phrases. Thick felt tin pens I used to use. That was so if I had to consult the document again, that I could skim read it and remind myself of what I'd thought were the really key telling sentences. And then this is the way I think a minister was expected to work. But as I taught myself how to be a minister. Sort of, because no introduction or management training of any kind was ever given to ministers in my day, when I started. So I would do this thing underlining, and I always scribbled on the top. Practically everything in the box would have my underlining, so they'd realise I'd reached it. Sometimes if I hadn't finished the box, they could tell which papers I'd not reached, and they put them in the next night's box, because there were no markings on the ones I hadn't reached, and they put the most important ones on the top. If I'd have a particularly busy day and was going to have only a few hours sleep, and sometimes you didn't always finish them. I did do my boxes properly. And then I'd scribble at the top. Sometimes I'd just put content, you know. Sometimes I put a short sentence. Sometimes I put, we must have a meeting, get them in, you know, or whatever it is. And that kind of comment, which would be seen by the relevant member of my private office and would be their clue as to the next stop, or if it was just a comment, they might pass it back to the relevant thing, saying the Minister of State's read this and his only comment is. Obviously they called a meeting if I was asking for a meeting, or if I gave some strong opinion, they'd report the opinion and say, if you want to change it, perhaps you ought to come and see him if you don't agree with him, that kind of thing. But it was the private officer's job to filter the paper so it was manageable by one person, who had a very busy day every day in the office, and quite a busy day at the weekend usually. And then that was the way it went backwards and forwards. And particularly with me, they got used to dealing with me because they all got used to my habit of underlining everything when I read it, or the key phrases.
And is this
And
right?
they knew they could expect my reactions on the top.
And for the most part, those original documents with your own markings on have not been.
So I discover, because you produce thousands of documents, 90% of which I've never seen in my life, the tribunal has. There's a huge archive somewhere in the country, God knows where, but the Department of Health does not appear to archive the documents, the originals, that as they went to the minister or as came back from the minister. Obviously I got the same documents, but they're all pristine photocopies or something of the documents we then had. And there's a tiny number. I found about 2 or 3 which they're still photocopies, but they're photocopies of the ones that have got my underlining and writing on. But a red box in those days is when they got a red box back in the morning. My office would have expected every document in the thing to have some underlining, a bit of scribble on from me.
And you,
I mean, apart from the letters, all the letters I have to sign, and everything else would be in the red boxes.
and as I understand it, so that there's no mystery about it, you don't know what the system was for retaining those or why they're no longer available.
I had absolutely no involvement in keeping the archive. I don't think it was a high-profile, high-priority part of the Department of Health's responsibilities. Some poor soul drew the short straw of having to organise the archive.
In the course of your ministerial duties for the period 1982 to 1985, as far as you can recall, did you ever visit a regional transfusion centre?
I don't recall visiting one. I used to do, but no, I don't think I ever did visit a regional transfusion centre. My only first-hand experience of the blood transfusion service was I was a blood donor. I think I was a blood donor in those days.
Did you ever visit a haemophilia centre, as far as you can recall?
A haemophilia centre?
Yes.
No, never. I don't think that.
Did you meet with clinicians? Generally, did you have meetings with clinicians from time to time?
Very occasionally. I mean, I would meet them, but because they'd always get me along to dinners. So medical dinners I would go to, but they were. That's how I'd meet a lot of doctors, because, not surprisingly, if you get invited along to a dinner of the Royal College or whatever it is, most of the evening would be spent with various doctors lobbying you, or you're asking questions of doctors. It was, I mean, the social side of it, that was the main contact I had with practitioners. For groups of practitioners to come in, I don't know. I mean, unfortunately, I don't think anybody's kept my ministerial diaries. They've not made their way to the archive. But I don't recall very often meeting. I mean, when I visited a hospital, of course, you spend your entire time in the company of the doctors who worked in that hospital, who would spend their time showing you what they're doing, going around explaining things, and lobbying you sometimes. Or
what about patient groups? Did you meet with representative patient groups?
We didn't have many patients groups. No, I didn't meet with many patients groups, although, despite what I was saying about that, I thought getting the service to concentrate on outcomes to patients as its main objective, and not relationship with its principal trades unions as its main concern, was one of my major activities during the time I was there.
And did you ever meet with people who had haemophilia, who suffered from bleeding disorders?
I don't recall ever meeting him. In fact, I've rarely in my life met anybody with haemophilia, I think I have to admit.
I just pick up on a phrase you used earlier in relation to doctors. You talked, I think, about clinical independence, and I think either your statement or certainly the statements of others have referred to the concept in terms of clinical freedom. What did you understand by that at the time?
Certainly, the government and politicians should not start interfering with the way that they treated their patients. That they their principal responsibility, the very great role of a doctor, is to be quite independently responsible for giving what he or she thinks is the best treatment to the patient they're trying to help. And they should not be inhibited by anybody. They shouldn't, by lobbyists or anybody else, in using their best clinical judgment in the interests of the patient they're treating. And so the medicines they prescribe, the treatment they give, all that is entirely the discretion of the doctor. I had disputes with them in a quite separate area, because I think the prescribing of medicines began to be abused with the prescribing of totally non-medical things by doctors lobbied by their patients. And I tried to, and prescribing very expensive versions of drugs which the health service could obtain much more reasonably priced generic alternatives to. That was the only issue I had, where those who disagreed with me started hurling allegations at me of interfering with their clinical freedom.
I understand why the department would not interfere with an individual clinician's dealings with an individual patient. But more broadly, would you accept that doctors were employed by the National Health Service, for whom the ministers within the Department of Health were politically responsible, politically accountable?
Well, they were employed by some of them were employed by the health service. I mean, GPs have always been, they're private sector. They're independent, self-employed people, or they're in partnerships, and they're in contract with the thing. We've always been a large private sector part in the health service, like the community pharmacists. They're not employed by the health service. Now, the hospital staff are all employed by the health service. Which means their employer is the National Health Service, which is the responsibility of the ministers. But that would have been an outrage if some minister had thought that meant you suddenly told doctors that you give this treatment and you don't give that treatment for a particular condition.
Would you accept that the department and the ministers within the department had a responsibility to ensure that the treatment being provided through the National Health Service to patients was safe?
Yes, that's why we have this network of safety of medicines committees, licensing authorities. They have legal power. It's illegal for the doctors. That's the real control, to make sure you don't have some eccentric doctor who is prescribing things which are not actually clinically proven or recommended. But never does the minister personally start intervening and imposing a personal decision on what treatment a patient should involve. Now, I mean, the great borderlines to all this. Just to give you an example of a problem which we won't get any further unless you particularly want to, but homeopathy, which is an alternative medicine, regarded by the vast majority of the medical profession as crank nonsense. For historic reasons, homeopathy was provided by part of the health service. We even had a homeopathic hospital, for reasons I won't go into. It dated back to the 1940s. I mean, so that was a fringe thing, because the overwhelming majority of medics, I mean, I'm not entering into this dispute, but the vast majority of medics would say that the treatment was useless. And indeed, I've known medics get quite excited about homeopathy, but there are specialists in homeopathic medicines who insist that they're entitled to provide it. And I say we had I think it's much diminished now. I think it's vanishing, but I'm out of date. They had fringes like that, but if that was ever resolved, it would in the end be resolved by medical opinion. You couldn't just have a minister could only intervene if the medics had told him that they're killing people, you've got to stop them.
If the department, whether through the chief medical officer or otherwise, were to publish and make available to health authorities, hospitals, clinicians, information about an emerging new virus, what was known to be the risks, what might be the pros and cons of particular measures that could minimise that risk, that wouldn't be an interference with clinical freedom.
Well, the CMO did that, didn't he?
Not in 1982, 83 or 84, no.
Did he not? I thought the CMO occasionally put out newsletters and things.
The first newsletter that we'll look at, I think, in relation to AIDS from the CMO is in 1985.
Yeah, well, that was the decision of the CMO. The CMO couldn't, it wouldn't do it much. I mean, the main source, the doctors on the ground, we're obviously frightfully worried. I mean, I'm not sure, whatever stage you're talking about, time it by concern grew. So the people mainly involved here, and most of the issues in all this are actually issues for specialists in haemophilia in the health service and specialists in AIDS in the health service. They would all be very concerned. Now, their main source of information, apart from each other and their conferences, would be the medical journals, where all the latest research, information, and so on is published. So if you're a worried doctor wanting to know more about where on earth is this disease coming from, are there some terrible downsides to this treatment, you would go to the Lancet. And the Lancet's only one of large numbers of journals where streams of research papers come out, and any doctor wanting the most up-to-date knowledge relies on that and his colleagues, not the Department of Health, certainly not politicians in the Department of Health, to which if any politician started giving an opinion, any sane doctor would say, what the devil has it got to do with him? And the medical profession is a self-governing profession. It's an outstanding profession, and the process of constantly changing clinical progress and medical advance, which makes the health service now vastly better than it was in the 1980s. It's huge, we're living in a far better world now than in the 1980s because of all the fantastic clinical advance. It's the professional organisations, it's the journals, it's the dissemination of scientific research. That's where you get your information from. People don't look, the doctors in the field don't look to the Department of Health to tell them what to do when it comes to treatment.
There are specialist clinicians who have told this inquiry that it would have been enormously helpful for them to have advice from the departmental chief medical officer in this critical time in the early part.
On what subject?
In relation to AIDS and how to deal with the risk of...
Well, if the chief medical officers had got, what did Diana Walford say?
There's nothing... My question to you, Lord Clarke, is this. There was nothing to stop the department, whether through the chief medical officer or otherwise, from providing information and guidance and advice.
No, I thought they did occasionally, but they had to be cautious, and they couldn't issue instructions.
So I note the time, and I'm going to move on to a slightly different topic, so it might be a good time for the first break.
Yes, I just would like to say two things before we do break. The first is that, as people here will be aware, the media have a particular interest, no doubt because of the prominence of Lord Clarke, in the evidence that we're hearing this week. I thought it was the right time just to remind the press, who've been very, very good, I have to say, up till now, that they should not, please, take any photographs either in or outside the building in the immediate vicinity without checking that the person that they're photographing wishes and is happy to be photographed, and taking care that others in the background aren't simply identified or identifiable by mistake. I've said this on a number of occasions, or words to this effect, and it's now, I think, an appropriate time just to remind those out there on whose cooperation we do depend and which we do value. Lord Clarke, what I say to all witnesses who are giving evidence at this stage in their evidence is there'll be a break. In that break, it'll be about half an hour on this occasion, there'll be longer breaks later on, and of course you'll be here for 3 days. At any break, you must not talk to anyone about the evidence you have given or the evidence which you expect you may be asked to give. You can talk about anything else you like. You'll know this sort of warning from your days at the bar.
Precisely. I am familiar with that. No, I'm not going to. I assure you, until I've finished giving you my evidence, I'm not going to discuss my evidence with anybody.
Thank you very much. Well, we'll take a break now and come back at 10 to 12.
Can I safely leave these papers here?
You can, yes.
They're safe.
Lord Clarke, can I ask you to look at your statement? Seamus, if we could have the statement on screen and go to page 18, paragraph 3.1.
Unfortunately, I'm so short of digital skills, I don't know how to get the page. Oh,
you don't need to do anything.
You're putting it up for me, right, surely?
So you will see in paragraph 3.1, you say, I've been asked about my knowledge of the National Blood Transfusion Service, the safety of blood and blood products, and the risks of infection on taking office. I do not think I would have received any briefing on these issues when I took office, as they did not fall within my ministerial areas of responsibility, and there were so many issues that did fall within my areas of responsibility that had to be covered. Just pausing there, would you have expected that the minister who did have that special responsibility, whether at any point in time it was Lord Glenarthur or somebody else, that they would have a briefing on those issues on taking up their role?
Yes. I mean, when who did Lord Glenarthur succeed? I can't remember. Anyway, whoever it was.
Lord Trefgarne, I think.
Lord
Trefgarne.
Lord Trefgarne. When Simon succeeded David Trefgarne, I imagine he was provided with, at some stage, with briefing on the blood transfusion service, yes.
Now, in broad terms, and I'm not looking here at any particular point in time between 1982 and 1985, but in broad terms, you had an awareness that concentrates, factor VIII concentrates, were being imported from the United States. Is that right?
I think, yeah. I mean, we kind of picked it up. I mean, you were aware of what was going on in conversation with colleagues and things. Yes, I did. The answer is yes, I did know that, and I knew only from the newspapers that there was concern about the importation to the United States of blood products, because that had got into the newspapers.
Now, although you, for the reasons you've set out in your statement, didn't have any specific briefing on the issue when you took up your post, did you have any general knowledge, as far as you can recall, about the concerns about use of imported products? There'd been a high-profile documentary, for example, in 1975 and another in 1980. Was that something, do you think you did?
I don't remember seeing a television documentary, but yeah, I had a kind of general. I'm sure I had read in the newspapers this concern about, because we had discovered that the Americans were taking paid blood donations, and the paid blood donations, what was always cited was prisoners, people in US prisons. But otherwise, people who were just down and out were getting money by selling blood for the transfusion service. And I had the general knowledge of a member of the public that there was concern about this, which so I did. I had followed it a bit, but I had no detailed special knowledge of it.
And then if we look, just by way of example, at DHSC 0000188, the document will come up in front of you, Lord Clarke. You'll see this is a written parliamentary question and answer, 5th of July 1983. And it's a Mr. Hamilton asking you two questions.
Yes, Willie Hamilton.
The first is about number of units of Factor 8 currently imported from the United States, what the figure was in each of the last 4 years, and if he'll take steps to reduce British dependence on a foreign product. And the second question is to ask the Secretary of State, in view of the risk of hepatitis in United States Factor 8, if he will take steps to enable the British Blood Products Laboratory to produce all UK requirements of this commodity. And then just, if we look at the answer before I ask you a question about it, your answer, written answer, detailed statistics of imports of Factor 8 are not collected centrally. However, approximately 35 million units of imported Factor 8 were used in 1981, which is the latest year for which figures are available. And then you go on to talk about the redevelopment of the Blood Products Laboratory, which I'll come on to at a later stage. Can we just go back to the paragraph in the middle? So you will have seen, Lord Clarke, from that second question asked by Mr. Hamilton, reference to the risk of hepatitis in American Factor 8. Do you recall becoming aware or being aware that hepatitis was a particular...
I think I was aware of the hepatitis risk. For some reason, the impression I have, as someone who's by and large a spectator of these events, the reasons I've already given, because I was never day-to-day directly responsible for the subject. I was aware of these concerns. Because AIDS was such a dominant, I mean, we forget now how AIDS really did grip the public and the media when it first, not surprisingly, when it first burst upon us. Less attention was paid to hepatitis, but I think I realised that, you know, AIDS wasn't the only infection you could get. Indeed, that infected blood was, on the whole, thoroughly bad idea. All kinds of things you could get from infected blood if you got very unlucky in your donors. So I was aware of it, yes.
And do you recall whether you had any particular understanding of how serious hepatitis could be in the early 80s?
So I am a layman, not a medic, but yeah, I think so, yes. I mean, it can be fatal. Certain types of hepatitis.
We can take that down, thank you. Now, do you recall how you first learnt about the possibility of a connection between AIDS and blood or blood products?
From the newspapers, I think, before I got to the department.
So something you think you might have picked up from the media generally?
I think so. I can't remember now where I first heard it, but I mean, trying to recall where you first heard something 40 years ago is tricky. I mean, I had not closely followed the subject, but I had the awareness of someone who, well, you know, as most politicians do, regularly followed the media.
We'll look at various specific documents very shortly, but just really some general questions. There came a point in 1983 when you would have found out, the documents show this, the precise date doesn't matter for the purposes of my question, that a haemophiliac in the United Kingdom was thought to be suffering from AIDS. Would you have expected the department to find out as much as it could about that case?
Of course.
And then there came a point a little later in 1983 when the first haemophiliac infected with AIDS through their treatment died. Again, would you have expected the department to try and find out as much as it could about that case?
Well, I've seen when doing my evidence that I had discussions in which this came up. I became aware that people had died because I got involved. I have to turn to my evidence to remind, because it's only from the documents that I can remember how I got involved. But yeah, well, where? I mean, what do you mean the details? It depends what details you're talking about. The fact that we had, I think, 2 or 3 haemophiliacs die, and it was definitely a strong possibility that they had died as a result of taking infected imported factor 8. I think he did know, and I can see from the documents. I was aware of that myself. When you say know the details, whether they actually knew the name and address of the victim and had interviewed GP and all that, I have no idea. But I think that's quite irrelevant. But I've no reason to think anybody in the department didn't know that we had this situation which had arisen where there was quite a strong possibility that someone had died as a result of being infected by factor 8, a blood product.
Yes, just so.
But if you at this distance, I can't remember when in 1983 all that emerged and became clear and all that sort of thing.
We can trace that through with the documents to the extent that we need to. Just to be clear, Lord Clarke, I wasn't suggesting that the department should find out the name, address, date of birth, and
absolutely
and personal
interview the
individual.
relatives and all that.
But would you expect the department to want to find out as much as it could about what
in broad
products?
terms, I don't know what you're getting at. In broad terms, when you have a significant event of this kind, obviously a cause of death which we'd not encountered before, I would expect the department to know about it and, if necessary, find out a bit more about it. But although I also expect perhaps that the people, the specialist doctors who also had encountered this for the first time, would get hold of the department and tell the department that they'd got this. What's the department aware? They'd had this rather tragic and unexpected thing happen. I mean, in broad terms, it all depends on what do you mean about what they need to know. But yes, of course, it'd be rather bad if the department apparently didn't even know that it had happened. But I think they did know that it happened.
Look, like I'm not suggesting that or trying to get at anything.
What are you suggesting? They should have found out that they didn't?
No, I'm asking you the question. Let me put it a different way, Lord Clarke. What kind of investigations or inquiries would you expect the department to undertake?
I would expect them to get hold of the medics concerned and say, to get the medics to explain to them what had happened in this case. But then maybe, again, I'm a layman, so I don't know how the medics in the department should have set about finding out more about it. They would know. Now you should ask the medics all that.
Lord Glenarthur told us that he recalled asking for a meeting with you and Mr. Patton in around September of, in September of 1983, because he wanted to raise some concerns about the way in which risk was being considered and the way in which the balance of risk was being struck. And he couldn't remember the details of the meeting, but came away feeling a degree reassured by the discussions that had taken place. Have you got any recollection of that?
I have. It's in my evidence as well. Indeed, my first, because I don't remember, I never held my own meetings on things. I was never directly involved in all this. I do remember that, and I put it in my evidence. I didn't consult Simon doing my evidence. Simon, that's when I really I improved my awareness of what was going on. Simon asked for a meeting with me, which the last few days I've read Simon Glenarthur's written evidence. This was when it was made public last week. So I now see he thinks John Patton was there as well, who was also a junior minister. Anyway, I remember Simon asking to meet me in order to discuss AIDS and so on, which was quite interesting because I filled me in a way which I had not been filled in before. But what the purpose of the meeting which I vaguely remember, I can't remember what each of us said or anything, was I think Simon just wanted to explain what he was, though it was his subject, what he was doing, how he was coping with it, and just see what his colleagues, because we're all friends, we're all on good friendly terms, what did we have any suggestions? Did we agree with his approach? What was our reaction? And we just, I don't know how long it took, an hour or so, I don't know, I can't remember. And we discussed it, and we all came to the same conclusions. I think he was also, anything you think I should be doing about it was what he wanted to know. And we all wound up in roughly the same place. He seemed to be doing sensible things. I could understand why he was concerned about it. If he found it reassuring that we saw no reason, we didn't disagree with the views he was taking. I mean, Simon, you've seen Simon. He's a good, intelligent, conscientious, very conscientious guy. And I trusted Simon's judgment, but no two people always agree. We might have come to different conclusions. We touched base. And from my point of view, it, I think, greatly improved my understanding of this issue, which I was aware was going on, but which I'd never been directly involved in, apart from all kinds of slightly irrelevant things like discussions of the wording of AIDS leaflets and things. But I'd never been involved in the main policy on it. And we touched base, and he found it reassuring, and I find it reassuring in the sense that I would have intervened if my role as Minister of State, if I'd thought one of the party sects was, in my opinion, screwing up on some rather important topic, then I would have told my office we'd better get involved in all this and see quite what they're up to and get reassured. Nothing had ever occurred to make me do that on blood products. And so it was just a generally reassuring meeting, and because every now and again it does help. You have a team of ministers, and we're a good team. This really was a team. We're all on reasonable terms. And I think I don't think anybody. We didn't have a lightweight or someone not really up to it. And every now and again, touching base with your colleagues and just making sure that they reassure you that they can't think that they're doing anything that you're not doing, and can't think of anything to do that you're not doing, and talk it through and just reassure each other that we were doing what we could. But Simon was in charge. I don't think. That's why I don't know what this inquiries. I don't think Simon did anything that there's nothing that Simon could have done that he didn't do about the whole thing.
Well, we'll explore today and tomorrow, Lord Clarke, what was and wasn't done. I want to start next then with a topic that you did become involved in. You referred to it in passing a moment ago. The question of a leaflet to be provided to blood donors.
Yeah.
And I'm going to do that by reference to the documents, and I'm afraid we're going to need to go through them quite slowly so that everyone can follow the sequence of events. So if we start, Seamus, with DHSC 0002309_024. We'll see this is a minute dated the 1st of July 1983. It's from Mr. Parker. It's addressed to Mr. Joyce, who was in Lord Glenarthur's private office. But we see there it's copied to a number of people. Mr. Alcock was your private office, I think.
He was.
So a minute that was copied to you. If we go further up the page.
But as I've said, every document in the department was copied around all the ministers. Doesn't mean every minister saw it.
I think I'll ask you about that in a moment, Lord Clarke, but I think we can probably infer from subsequent events you did become involved in this issue.
I became involved. I got involved in the leaflet. That is true.
Yes, and that's what this minute is about. So we can see Mr. Parker says, I attach a paper, flag A, prepared by Dr. Wolford, which seeks ministers' agreement to the funding and publication by the department of an information leaflet on AIDS, flag B, for distribution by the National Blood Transfusion Service. Lord Glenarthur will be aware from Dr. Wolford's note of the 22nd of June, copy attached at flag C for ease of reference, of the steps being taken by the department to prevent the spread of AIDS in the UK, and a further submission covering the imports of blood products, developments in technology, research and UK production of Factor VIII will shortly be put to ministers. Meanwhile, in view of the public interest in AIDS, the issue of the leaflet would be seen as a positive step to minimise the risk of the transmission of the disease through blood donation in this country.
Yeah, now I've not seen this document before, I don't think. The point of the document was to try to discourage homosexuals from giving blood, wasn't it?
Yes, those in high-risk groups.
Yeah, so to get down to the point, that's what
Yes.
what rather significant step it represented.
So if we just take it in stages, I'm just going to read out, but not go to, the references for the documents described as Flag B and Flag C. So that I'm doing that, Lord Clarke, not because I'm going to ask you about those particular documents, but so that the references are on the record and others can find them.
Okay.
So the draft leaflet described at Flag B, and Chairman, you don't need to put this up, is DHSC 0002309_112, and the background paper referred to as Flag C from Dr. Wolford is DHSC 0002309_124. But I do want to go to the document referred to as Flag A, so that's the submission to ministers about the leaflet. Shomik, that's DHSC 0002309_121, please.
What is the date of all this?
This is sent under cover of a minute dated the 1st of July 1983. And we'll see, Lord Clarke, you become involved in a discussion about this on the 6th of July. I'll take you to that, but I just need to take
I remember getting involved in it.
So I'm just going to read out certain parts of the submission. We can see the heading is Acquired Immune Deficiency Syndrome, issue of an information leaflet through the National Blood Transfusion Service. Purpose of the paper: an information leaflet on AIDS has been prepared by the regional blood transfusion directors. Its main purpose is to discourage practising male homosexuals who as a group carry the highest risk of transmitting AIDS in their blood to refrain from donation. Funds are available for the department to pay for the printing of the leaflet, estimated cost approximately £5,000, which would be distributed by the National Blood Transfusion Service. In view of the sensitivity of the issue as it relates to homosexuals, Minister's agreement is sought to the funding and publication of the leaflet. And then, we don't need to read all of it, but we can see under the heading Background, it says there is increasing evidence that AIDS may be transmitted by the transfusion of blood, which is taken from a person who is either suffering from AIDS or who is in the incubation period of the disease. Blood products such as factor VIII for the treatment of haemophilia may also transmit AIDS, and haemophiliacs are at particular risk because of contracting the disease because factor VIII concentrates are made from the pooled plasma of up to 5,000 donors. In this country, there have been 12 confirmed cases of AIDS, 11 of which have occurred in homosexuals and 1 in a haemophiliac. It is believed that there may be underreporting of cases. And then the next paragraph begins, although there is no conclusive evidence, it seems very likely that AIDS is caused by an as yet unidentified virus. There's no laboratory or other test which can be used to detect AIDS in the blood of a potential donor. In the absence of such a test, blood transfusion directors are anxious that information on AIDS should be made available to blood donors, and that promiscuous male homosexuals, who as a group carry the highest risk of transmitting AIDS in their blood, should be discouraged from donating. There is absolutely no intention, however, that donors should be questioned about their sexual habits or be required to undergo a routine physical examination. There's then reference to the leaflet itself. If we go to the next paragraph, there's reference to a draft resolution of the Council of Europe, and I'll come back to that later, Lord Clarke. And then bottom of the page is headed Sensitive Issues. It is possible that a request to homosexual donors to refrain from donating could be interpreted by homosexual rights groups as a discriminatory move, which would infringe their rights as individuals to donate their blood. Such a reaction would be more likely to arise if there were widespread misunderstanding of the nature of the problem posed by AIDS, and transfusion directors are anxious to preempt such misunderstanding by publishing their information leaflet as quickly as possible. And then there's reference to the cooperation of the Gay Medical Association. We can skip over that. And then if we go to the recommendation, in spite of the potential sensitivity of the issue, officials are of the view that early publication of the information leaflet is in the best interest of the public health. Ministers are asked if they will agree to the funding and publication by the Department of the information leaflet for distribution by the National Blood Transfusion Service. So is it right to understand from that, Lord Clarke, that ministers, and we know this came to you and you became involved as well as Lord Glenarthur and indeed I think Mr Patten, were being told that this was something that should be done as soon as practicable? It was something that officials wanted to get on with.
Yeah, I can't remember when I first came aware of it. I'm not sure whether I was shown this. Probably my office probably would have shown me this because it was a very big step. And as you say, I got involved because it was a problem. The handling of it was quite important. To say that we were actually discouraging homosexuals, concentrates on what it calls promiscuous homosexuals, from donating blood because they might be giving people AIDS. Big stuff. And it wasn't a minor step. Obviously, no one argued, no one tried to stop printing the leaflet. Don't think it was plain necessary to do it. But handling it was quite careful because the press were behaving appallingly over AIDS. The background, I mean, as we all know, is homophobia was widespread and actually regarded as rather normal in the 1980s. Attitudes have changed enormously in the decades since. And the press were quite homophobic. So queer blood kills people was, the language wasn't very far removed from that in the reporting of it in the tabloid press. And there were various risks involved in how you handle this. You have unintentional effects. The most important was that you put, what I was worried about was I didn't want it to be done in such a way that we stopped people volunteering to donate blood. We need blood donors. And so just to make sure, to underline what was in this document, that people were not going to be told they were going to be quizzed about their sex lives when they turned up to donate blood, and that we weren't, just going to be homophobic for the sake of it when people gave blood and people like that. And I really was very worried. We didn't want people put off from blood transfusions. We didn't want the more normal patients, patients of ordinary sensitivities and opinions, to suddenly think that they were going to refuse to have a blood transfusion. They weren't going to have the operation because they were going to be killed by the blood that they were taking. So you had to handle it carefully to avoid mainly changes in public attitudes and needless fears. A very important step to make the service safer, but no need to panic. Certainly we don't want people to stop donating blood. Certainly we don't want patients to start refusing operations because they're frightened of a blood transfusion. And that was the only basis on which I intervened. I never got involved in the detailed drafting of it or anything like that.
Well, let's just follow that through, Lord Clarke, if we may. So that minute is dated the 1st of July. If we go next to DHSC 0002309_025, we'll see there, 4th of July, Lord Glenarthur indicated that he was content with the...
well, it was for him to approve it and he took 3 days.
Yeah. And then if we look at DHSC 0002309_027, we can see this is on behalf of Mr Patten. This is the 6th of July. He says, in my view, public concern on this issue is mounting and rightly. The earliest possible publication seems desirable. And then a reference to the Gay Medical Association could perhaps deal with the issue of discrimination. So 4th and 6th of July, Lord Glenarthur and Mr Patten indicating their approval. We'll then turn to how and when you became involved. If we look at DHSC 0001511, please. So you'll see, Lord Clarke, this is a minute dated, if you just go to the bottom of the page, 6th of July, and it's authored by Stephen Alcock in your private office. If we go to the top of the page, we can see it's described MSH, so that's you, Minister of State for Health, meeting note. The meeting date is the 6th of July, and it's a meeting participated in by you, Lord Glenarthur, and then the 3 civil servants, including Dr. Oliver, who was a medical civil servant listed there. 1, MSH had 2 main concerns: to establish the necessity of a leaflet and to agree how the inevitable publicity surrounding it should be handled. I'm going to read out the minute, Lord Clarke, and then ask you about it.
Yeah, sure.
2, officials felt that ministers did not have the option of doing nothing. The main objective of the leaflet was to discourage those who were most at risk from AIDS from giving blood, and thereby spreading the infection to patients who needed large amounts of blood, principally haemophiliacs. Similar guidance had been issued by the American Blood Transfusion Service, and the Council of Europe had recommended that its member state should put out a warning. Moreover, one of the regional transfusion directors had let slip to the press that a leaflet was in the offing, and if nothing was now done, speculation would be rife. Paragraph 3, MSH, so that's you, accepted the strength of these arguments. He thought the leaflet as drafted read well, although he would like it to emphasise more strongly how few cases of AIDS there had been in the UK, perhaps by quoting numbers. It should also emphasise unequivocally that donors would not be questioned about sexual matters when giving blood. It was inevitable that the leaflet would attract wide publicity, and a carefully drafted press notice and full question and answer briefing would be needed. To minimise the scaremongering, the press notice should emphasise how relatively few cases of AIDS have been reported, and repeat that there was no question of donors being quizzed about their sexual habits. The main objective was to minimise any damage to the transfusion service. The announcement should be made at the same time as the leaflets were released. Paragraph 4, Lord Glenarthur would be answering an oral PQ, parliamentary question, about AIDS from Baroness Dudley on 14 July. If she asked about the blood transfusion service, Lord Glenarthur should emphasise that the risk to haemophiliacs was very small. So if we go back to the top of the page, paragraph 1, it would appear, Lord Clarke, or it might be inferred from this document, that this was a meeting called at your instigation.
It possibly was. I'd forgotten I called a meeting, but my recollection is that I actually chose to intervene for the reasons I've given. I was worried about the press creating an absolute panic. I was worried about our losing blood donors. I was worried about alarming recipients, both haemophiliacs, but more actually blood transfusion people as well, which I thought I was also, well, I think I was concerned about, but it doesn't appear from this. I mean, that didn't take them long to persuade me we had to put out a leaflet. It was a very important leaflet. That's what I intervened for, because if we'd not handled it carefully, we could have created absolute mayhem. Somewhere in the documents, I think they'd had problems in New York when they did it there. They had started losing blood donors, I think. So that was, I wasn't intervening to try and alter the policy. Just how do we handle it, but just don't start mad panic with, I mean, if haemophiliacs had stopped taking their factor VIII, they would have died, some of them. And so, just the way you handle it.
Well, the answer you've given there is an important one, but one I'm going to come back to later, what the impact would have been on haemophiliacs. So leave that to one side for now, but I want to explore that with you at a later stage of your evidence. But just in with this meeting, is it right then to understand from this, you instigated a meeting, you wanted to decide whether it was necessary that there should be a leaflet, and the consensus was at the end of the meeting, it appears that you accepted it should be.
Yeah.
But it would also appear from paragraph 3 that you were expressing views about what should be in the leaflet. In 2 respects, you wanted the emphasis on how few cases of AIDS there have been, and an emphasis on the lack of questioning of donors. Is that right?
Emphasis on what was the first one?
How few cases of AIDS there had been in the UK.
Yep.
Well, why was it seen as important to you to emphasise that fact?
Well, to try to minimise panic before we knew more about it.
And then the penultimate sentence of that paragraph, the main objective was to minimise any damage to the transfusion service. Are you able to assist us with understanding what you meant by that?
I didn't want to start putting donors off, or to destroy public confidence in the blood they were given by blood transfusions.
And then if we look at paragraph 4, now this doesn't attribute what's being said in paragraph 4 to any particular individual. It says in the second sentence that if she, Baroness Dudley, asked about the blood transfusion service, Lord Glenarthur should emphasise that
That reads as though it's a conclusion we all came to.
Yes, you may be right there. But, Lord Clarke, why was it seen as important to emphasise that the risk to haemophiliacs was very small?
Because until we knew more about it, we didn't want to cause mad panic. And those sections of the media on this particular subject perfectly capable of causing mad panic.
Having had that meeting on the 6th of July to discuss the need for and content of the meeting, if we look next at DHSC 0002321_026, please.
I'd go back to that. That seems all to be agreed in the end. I mean, I always said, at all meetings, if any of the other 5 people there disagreed with me, they could sit there and say they disagreed with me and try and argue me out of it. We obviously, the conclusions we reached were the conclusions we all reached in the end. In the real world, you can't get a dozen people together for a meeting and sit them down and all 12 will agree 100%. You can get 12 medics and you won't get 100% agreement between a group of medics, even specialists. So you start where you start from. I had all these concerns about, I didn't mind leaflet going. I don't think that took very long. I just wanted to check as they were having a meeting, as opposed to just reading about it. We do need this leaflet, don't we? Well, the only reason I ever intervened, I wouldn't have had anything to do with it otherwise, was I just wanted to make sure we didn't accidentally cause these habits to blood transfusion service. If the others had strongly disagreed with me, they would have sat there and strongly disagreed with me. And we appear to have reached a conclusion that Simon Glenarthur would make it clear we hadn't had many cases. We'd only had one case, I think, we said, of AIDS by being possibly, probably transmitted by blood product.
If we then look at DHSC 00, sorry, you got it on the screen. Thank you, Shomik. So, Lord Clarke, you'll see this is a minute dated the 19th of July 1983. It's from Mr. Parker in the Health Services Division, and if we go to the top of the page, it's addressed to Dr. Oliver in the Med SEB. Now, this is not a document that you would probably have seen at the time, but it refers to...
But I've seen from the documents, we had this discussion about should they be distributed with the call-up cards or not?
Yes, and that's what I wanted to ask you about next. So having established the need for a leaflet on the 6th of July at that meeting, there then arose an issue about how they should be distributed. And if we just pick up here, it sets out Mr. Parker's recollection of your position in paragraph 2. If my memory serves me correctly, I understood MSH, that's you, Lord Clarke, to say at the meeting we had with Lord Glenarthur that he would prefer some consistency of approach in relation to the distribution of the leaflet, but did not want it to be distributed.
That was my view inside the discussion. There were a whole lot of documents which I've now seen. I can't remember any of them, and I can't remember the issue now. I have to rely on the documents as you do. But yeah, I took the view, so, as other people did, there was a division. I seem to recall some of the regional transfusion officers agreed with me. Some didn't. Virginia Bottomley, I think, agreed with me. Other ministers didn't. It was one of the things we were discussing. Yeah, but my view was that for potential blood donors, I was a bit worried that getting this leaflet with the call-up card, because don't understand the leaflet. It's pretty startling that you're putting out a leaflet telling gays not to give blood. Can't think of any equivalent of that for a long time. So no one can say we weren't taking the risk seriously. That's laughable. We were actually stopping gays giving blood. Now, if you've got a call-up card, and here with it is this leaflet telling you if you're gay not to give blood, you've got to be careful about that. Some people say, what are you calling me gay for? I'm not gay. Some gays would say, good grief, what have they got against gays? Not even the Department of Health's getting homophobic. So we were divided. But I always was one of the ones. My view. I say I recall it is because I see the documents. Really, I obviously took the view that I did rather it didn't go out with call-up cards. The actual people who worked on the ground, the regional transfusion directors, were divided. So where we get to, just to get on a bit, the regional defence directors had different views. So we began by letting them each do what they wanted to do, and it took about a week to decide.
Well,
and then about a month to decide, and off they went, and we distributed the damn things, and because we hadn't reached consensus in the department, and because the regional transfusion directors hadn't reached consensus, we decided to see how we got along with the regional transfusion directors having discretion to do it whichever way they preferred. That's all there was to it.
you've accurately summarised the outcome, Lord Clarke, but I want to look at the decision-making process and the time it took to reach that outcome, which necessitates going through the documents, I'm afraid.
Well, what for?
Well, I don't really think that's something I'm...
Well, I gather you're doing
Right,
that.
Lord Clarke.
Every policy decision I've ever been involved in has involved some discussion and exchange of views. Once in the end you've reached a decision and ministers and officials are content with this and are acting, I mean, as a matter of history, I suppose it's fascinating to know who started the meeting saying what, and before we all came round to the same view in the end. What matters is what did you actually do? So I've never been to a meeting. I've never been to a meeting of the cabinet where everybody's unanimous. But if at the end you've reached a unanimous decision, you've all agreed what you're going to do and what you're collectively responsible for, why do we have to go in such meticulous detail through who said what when, and when did he change his mind, and do you remember what actually persuaded you? You know, it's just frightfully interesting, no doubt, but pretty pointless.
Dr. Wolford described the delay in producing the leaflet in...
So it said what?
Dr. Wolford described the delay, the time it took to get to the stage of the leaflet being issued on the 1st of September, as I think the term she used was unconscionable, but certainly she described it in serious terms. Lord Glenarthur also told this inquiry it took too long to get to the point of 1st of September.
The second one took far too long.
They described, Dr. Wolford was concerned only with the first, and I'm going to
Well,
ask
I
you
was
about
away in
each,
August.
Lord.
I mean, it was my habit to take August. I wasn't in the department in August. So if Diana thinks that we took too long to September, I don't know how long it. I mean, God knows how long it took to print and distribute it. I mean, that's beyond reach of any of us.
About 3 weeks.
Yeah. So yeah.
Did you
That was,
understand?
I mean, I certainly took no part in it. But was this the cause of the delay?
Did you understand, Lord Clarke, that one donation from someone who had AIDS could lead to the infection with AIDS of large numbers of individuals?
I realised it was a strong possibility. We didn't know that then. But there was more and more concern that it's a very distinct possibility, and it was, you know, if not probability, that it did look as though there was a serious risk that one person could infect. Yes, I did know that. Similarly, we could have killed quite a lot of people if we'd suddenly caused a tremendous shortage of blood donations.
Again, we'll come back to that second point.
Well, you're saying all arguments are on the one hand this, on the one hand that. It's no good saying on the other hand doesn't matter.
We'll come back to that, Lord Clarke, I assure you. So just sticking, if we may, with the chronology in relation to the first leaflet, and then I'm afraid we're going to turn to the chronology in relation to the second leaflet.
Yeah.
Is it right to understand from this that you didn't want... you were expressing a view about how the leaflet should be distributed, and you didn't want it to go with the call-up cards?
Yeah, it's quite obvious from this and other documents.
And if we...
I only know it from the documents. I can't remember that was the view.
And if we look at DHSC 0002321_028, This is a minute of the 21st of July 1983. Again, not a minute that you would have seen at the time, but referring to the recollection of someone at the meeting as to how you reacted. At our meeting with MSH, he was very keen to keep the leaflet operation very low key. Therefore, I must support John Parker's memory of the meeting when he says MSH does not want the leaflet to go out with call-up cards. The leaflet is an information leaflet and cannot be seen as a leaflet which you read and then change your mind about giving blood. Just pausing there, Lord Clarke, and recognising this isn't a document authored by you, wasn't that exactly what the leaflet was for?
I think somebody pointed that out to me at some subsequent meeting.
And then
Obviously it was.
And indeed, you actually described it in those terms a moment or two ago.
Absolutely.
And then the last paragraph, I think MSH will be very irritated if we're not able to control distribution the way he wants it. He reacted very unfavourably when this was suggested at the meeting. Now, that would tend to suggest, I don't know if you can recall this or not, that this was a topic upon which you had fairly strong views.
Well, I rely, as you do, on the documents. I remember involving myself in it, and I can remember why I was involved in it. But not to stop the leaflet, not because I didn't realise it was extremely serious. As soon as possible, we got rid of this strong possibility that we were even going to kill people by giving them blood which had been donated by a homosexual. But because as I keep saying, I didn't want us accidentally to cause a public panic which would damage the blood transfusion service and public confidence in it. And I wasn't the only one. There were other people who agreed with me, including some of the regional transfusion directors didn't reach consensus either. They were equally divided. And they knew more about the blood transfusion service than I did.
If we come to then, and I'm going to skip over a couple of documents that we've looked at already with Lord Glenarthur, if we come to the submission that's then sent to your private office on the 29th of July 1983, DHSC 0002327_016, please show Mick.
This is all their reactions to the meeting. I obviously got quite strong, I think. What was the Gillick case that had obviously set me off? I can't remember that.
Can we go to the first page, Mick?
It's amazing how easy it is in the area of health to set off sort of public panic and do unintentional damage. It happens quite often, particularly with sections of the media.
So we'll see, this is Mr. Parker to Mr. Alcock, so your private office, 29th of July 1983, and it's attaching a submission seeking Minister's agreement to the printing, distribution arrangements and publicity for the proposed AIDS leaflet.
Yep.
So if we turn over the page to the submission, we can see top of the first paragraph reference to the text of the leaflet having been revised to incorporate the points made by ministers, and then there are various documents attached. Yep. We don't need to look at those. Distribution of leaflet is then described, and if we go just below the Roman paragraph...
Sorry, what did it say about it?
Well, I'm going to pick...
The method of distribution should be that which is the most effective in reducing the number of donations from high-risk donors. Excellent.
Yes, so that's one of the criteria.
Seems obvious common sense.
And then what's said is the two possible methods of distribution which are considered by regional transfusion directors are discussed below in relation to these criteria. One, issue of leaflet with donor call-up cards. So that was the proposal that you'd expressed some concern or irritation about. This could be expected to reach about 80% of the total donor population. In addition, leaflets could be sent in advance to donors booked on factory sessions. Walk-in donors would not be covered. So that's the first point. Top of the next page, a number of other advantages set out. B, donors could read the leaflet in their own homes, thus avoiding any embarrassment. C, the supposition is that this method of distribution would be the most effective in keeping high-risk donors away from sessions, thus removing the temptation to proceed with donation in order to avoid embarrassment. And then paragraph D refers to there being certain administrative and resource implications. So you're being told, is this right, Lord Clarke, in this submission, that the most effective method of distribution...
Well, in the opinion of this, but that's what we were discussing, yes. Obviously, in the opinion of whoever wrote that thing, when not everybody agreed with that.
But that's what you were being told.
By
And
this
then-
person, but I wasn't by other people, including regional transfusion directors.
And then
It
if we look-
wasn't the universal opinion in the department.
if we look at the second option,
You're just selecting little extracts as though there was one opinion which I was holding out against. There were people who agreed with me.
well, don't worry, we'll be looking at as many of the documents as we need to, Lord Clarke, rather than selected.
Well, we can go to a lot if we want. I don't quite sure the point of any of this is.
The second option, leaflet to be made available at donor sessions. E, it would be difficult to ensure all donors received a leaflet and there could be insufficient time for it to be read prior to donation. F, there are many other circumstances besides the risk of AIDS which lead to a donor being rejected for donation on a particular occasion. Donors could be caused embarrassment if they felt their fellow donors had wrongly suspected the reason for their rejection. G, if a donor in a high-risk group were to read the leaflet immediately prior to or during donation, he might well be tempted to proceed with the donation rather than to risk the embarrassment of
Yes, they're all quite good arguments.
And then H talks about this option having few administrative or resource implications. So, but before we look at the actual recommendation, and as you point out, Lord Clarke, the actual recommendation was to leave it to the discretion of directors. Would it be right to understand from what's set out about the two possible methods of distribution that what ministers were being told is that, in no uncertain terms, is that the most effective method of distribution would be the call-out card method?
In the opinion of whoever wrote this submission. But on the other hand, the problem, as I have just said, that if you received it with your call-up card, it was a rather startling leaflet when you were used to being a blood donor, you would get the impression that when you went to the blood donation, you're going to be quizzed about your sex life. And if you were, to quote the word that's been used in other leaflets, remotely promiscuous, you'd be told you couldn't give blood, and you might be put off continuing to volunteer. This just sets out the arguments on one side of the argument. Well, they are the arguments on that side of the argument. On the other side of the argument were the arguments I've been putting, which were agreed to by people in the department and by people in the regional transfusion service. We never reached a consensus. You've just found a document which the person who, the author of it, is putting the strong. They're perfectly, I mean, I'm not dismissing these arguments. They're all they're put perfectly rationally and clearly. But this happens all the time when you're taking tricky decisions. And in this particular case, what we're talking about is what is difficult to predict is the public reaction to the leaflet and the way you do it. You want the desirable objective, which is to remove the risk to haemophiliacs and receivers of blood transfusions. You want to avoid the undesirable consequences, which are you've suddenly started putting donors off, and you've suddenly got patients getting all excited about whether it's safe to have an operation. So this is one side of the argument, and the department was divided.
Could we go back to the very top of the memo? It's on the page before, I think. Thank you. And the page before that. What is said about the leaflet, Lord Clarke, is it's been prepared in consultation with colleagues in Med, Information Division and CH Division. So it looks, as far as that's concerned, that this is, so far as the department is concerned, a combined submission, does it not?
Those divisions, yes, sure.
So that's combined. There's no division then, no difference of view, I think, in the department, though I accept from the evidence we've heard, the evidence you're giving as well, that the regional transfusion directors on the ground may have taken different views, did indeed take different views. Have I understood it properly, Ms. Richards?
So you haven't, and indeed if we look at the fourth page, we'll see that as Lord Clarke has indicated, the actual decision ministers were asked to make, or that Lord Clarke was asked to make, was to leave it to the discretion of directors.
Was what?
to leave it to the discretion of directors for a trial period.
That's what it all concludes at the end, does it?
It is, yes.
So that was the recommendation.
So that was the recommendation. If we look it up, picking it up at the top of the page, where it says, although it would be possible to achieve a near uniformity of method of distribution among directors, it's not immediately obvious which method is to be preferred. Indeed, it was evident that directors' opinions were influenced by what they saw as being most appropriate in their regions, bearing in mind the differing population characteristics, including the numbers of and attitudes to homosexuals. As directors are responsible under the Medicines Act for the safety of the blood which they issue, due weight must of course be given to their clinical decisions in this matter. In addition, those regions for whom the agreed method has resource implications might look to the department to provide the additional resources. And then the next paragraph, we don't need to read the rest of it, but the next paragraph says, officials would recommend, therefore, that RTD's regional transfusion director should be given the discretion to decide, for a trial 6-month period, the most effective means of distribution in their own regions. Officials will be able to obtain regular feedback information from directors.
And that was agreed. That was what was in fact agreed, wasn't it?
It is, although I think it was a 3-month trial period that was ultimately
It was what, sir?
a 3-month trial period at Lord Glenarth's.
Yeah.
But just if we go back to the top of the first paragraph on that page, is it right to understand, if we look at the sentence beginning, as directors are responsible under the Medicines Act for the safety of the blood which they issue, due weight must of course be given to their clinical decisions. Is that, as it were, the principle of clinical freedom or clinical independence in operation?
Well, it's obviously the legal duty of the directors to ensure the safety of the blood. That's a kind of a legal obligation. You can't place them under a legal obligation. It's not clinical independence, no, because the clinician, I don't know whether the directors were all clinicians. It may be, but no, what it's actually, it speaks for itself. As they're under a legal duty, you can't just ignore their views on the best method of distribution.
The top of that paragraph says it's not immediately obvious which method is to be preferred. It might be thought, looking at the pros and cons of the two options that we looked at on the previous 2 pages, that it was pretty obvious that the method of call-up cards was thought to be
It was
the most
preferred by the people who've done it. It's pretty obvious if you take a sentence expressing the opposite view. It comes to the same document, comes to the conclusion, because it's obviously, after none of this had taken very long. We'd had one meeting apparently and had a discussion of it. And it comes to the conclusion, it is not immediately obvious which method is to be preferred. That's the conclusion the author actually eventually comes to. You're putting weight on one sentence the author had written a few paragraphs before.
Well, in fact...
One sentence in thousands of documents of something 40 years ago.
Inviting your attention to an analysis over a page and a half of pros and cons. But in any event...
There's a page and a half of pros and cons, and it was resolved by the methods described here. As you say, Simon seems to have changed the 6 months to 3 months. That should leave it to the discretion of the regional transfusion directors, who, as you pointed out to me, I had forgotten this, anyway, had a legal liability under the Medicines Act to be responsible for the safety of blood which they issue.
Now, if we just go back to the previous, to the second page of the document, please, Shomik. We can see paragraph 2, after where it says what's attached, it says the submission seeks your approval, so it's not in fact seeking Lord Glenarthur's.
Well, that's because I've been expressing that, because I had obviously intervened. I mean, I wouldn't have been involved in this at all if I had not intervened when I heard about it. Presumably, the copy, probably my private office pointed out to me, have you seen this? It's just been copied to us. And I intervened because I just wanted to make sure that we didn't start setting off some sort of mayhem that damaged the transfusion service. Obviously, I made no attempt whatever to stop it being printed.
So the fact that you had this wider ministerial responsibility and Lord Glenarthur was the minister, as you've emphasised, with special responsibility, didn't preclude you from becoming involved in the detail of decisions such as this, did it?
Yes, so if I intervened, then they would start taking notice of my views. But I did intervene on this particular issue, as I now see. I'm reminded by my actual personal recollection compared to what's set out of the documents is quite small.
Then if we just look at the response to the submission, because there were...
Just before we do that, can I just ask one question? You've raised there in your answer, indeed it's raised in part by the document, the legal responsibilities of the local regional transfusion director for the safety of the blood. If a particular director in a region thought it was necessary to ensure the safety of the blood in that region, that he should alert those who might be donors to the idea, however expressed, that those who were active homosexuals would not be welcome to give blood, and put out a leaflet to that effect, would they have been able to do that?
I don't know. It's an interesting question. I assume they would, really. I don't know whether the department would have tried to stop them. Anyway, that's what we were doing. I mean, no one was ignoring the risk. A leaflet was being put out nationally telling homosexuals that we didn't want them to give blood. So, I mean, no one was objecting to that.
What I think I was exploring in that question were the limits, albeit they were cultural rather than legal, on the way in which regional tribunal transfusion directors would actually exercise their discretion. In this particular case...
Well, I never had any direct dealings with the blood transfusion service. The answer is I don't know. I cited it legally because it's cited here. I didn't, until I read it 2 minutes ago, I didn't know. I could have forgotten. I mean, obviously it was once told, but I had forgotten that they had this, under this legal duty, which appears from this document to be one of the reasons cited by the author of the document for leaving it to their discretion. I never had any direct dealings. I don't remember ever meeting a regional transfusion director, and I don't know what how in practice they exercised any discretion they had for the local thing. Here, they're being allowed a discretion. Again, when I cited earlier on that some of the regional transfusion directors agreed with me, that was because I'd known, looking at the documents provided by this inquiry, that had first reminded me that the transfusion directors were divided as well. I think I wasn't the only person in the department. I think, I'm not sure which side John Patton was on. I have a faint recollection that Virginia, on the whole, tended to agree with me, but I'm not quite sure why I remember that. But there were, you know, that's actually I'm not sure now that this was 83. I'm not sure Virginia was in the department, but there we are. Actually, I think she was. Anyway, that's why I mentioned it. But I never required at any stage, my entire career, any day-to-day experience of how the regional transfusion directors worked. I never had any direct dealings with the blood transfusion service, except I was a donor.
Did it ever crop up in your conversations with the regional health authority chairman? Because that was your link with the region.
I don't remember this coming up with the RHA chairman, no.
Right, thank you very much.
If we just follow through the decision making, you responded with 2 minutes. The first is the 2nd of August, DHSC 0002327_119. Where we can see on the 2nd of August, you say, we just go back to the, thank you. You say in response to the submission, a lot of work has obviously gone into this. I'm content with it. I'm even prepared to allow directors discretion on how to distribute for 6 months as the arguments are finally balanced. Presumably we will then think again in the light of experience. I hope that this does not become a silly season story. Handle it in the DHSS through press office. Regional directors should not handle queries themselves. Go ahead with the leaflet as drafted in the press notice. So that was your response on the 2nd of August. Lord Glenarthur and Mr Patton also indicated their agreement. I'm not going to take you to those. But could we then look at DHSC 0002309_034? So having on the 2nd of August said go ahead, on the 26th of August, we have this minute where it's a communication from Mr. Naismith. Was that?
I obviously had a shorter holiday that year.
In your private office to Mr. Winstanley. We spoke. MSH has now seen the Q&A briefing and press statement prepared, together with information provided by ID, that's the Information Division, on the rather alarmist press coverage this subject has so far attracted, and has commented. The publicity is annoying, partly because it's what I feared and what we do not want. Docs ban gays, blood, etc. I'm concerned by the report that similar alarmist action caused a shortage of blood in New York. The range of views from directors is also alarming. Have we agreed on one method of using the leaflet? There could well be a fuss and a scare if different steps are taken in different parts of the country. What authority do I have to insist on one national method, and what are the options? So you would appear to be saying on the 26th of August, Lord Clarke, the opposite of what you'd said on the 2nd of August. Are you able to assist us in understanding?
Sorry, well, in what way?
Well, if we want to go back to the minutes on the 2nd...
It confirms that I thought my fears had been justified by... I can't remember these stories, but obviously we had silly season stuff about docs ban gays' blood.
Chairman, could we put the 2 minutes side by side? That might be easiest. So DHSC 0002337_119, side by side with the one on the screen. So we'll see on the 2nd of August, you're agreeing with the submission.
No, so this business of... I was agreeing in the first of the discretion to the regional directors.
Yes, and then on the 26th of July, so the one on the right-hand side, if we can look at that now, leave aside...
26th of August.
26th of August, thank you, sir. Leave aside your first paragraph talking about...
The range of views of directors, I obviously seem to have forgotten the range of views and directors, yeah.
And then you seem to be suggesting or asking if one method has been agreed, and asking if you have an authority to agree on one national method and what are the options. Are you able to explain why we see these...
I have no recollection of most of this indeed. I do seem to have changed my mind, yes. It didn't make any difference, did it?
Well, I think
what happened on the ground?
Not for me to answer questions, Lord
Well,
Clarke.
it is. What's the relevance of all this? What difference did it make on the ground?
I think the relevance ultimately, Lord Clarke, is for me to determine.
Yeah.
If I think that the questions are unhelpful, then I'll indicate that. But in the moment, it would be helpful to me, I think, and we may get on a little bit more quickly if we just deal with the questions as they come and leave the motive or the purpose of asking the questions to council and
anyway, the leaflet has been distributed, and everybody's aware of this, and it's been given quite a lot of publicity.
Just to complete the picture, and in fairness to you, Lord Clarke, there's a third minute I should just draw attention to from your private office, DHSC 0002321_034.
I'd obviously on my holiday forgotten that we had agreed on this discretion.
Yes,
no doubt I was quickly reminded and corrected.
And that's why I'm taking you to this third document, Lord
Yeah.
Clarke, because you were reminded and
I'm
corrected.
just asking if presumably I was rapidly pointed out to me that I had agreed to it, so I can't see
So
it made...
31st of August 1983 from Mr. Naismith to Mr. Winstanley in the Health Services branch. I've now spoken to the Minister of State for Health, who's commented as follows. When I saw the first submission, I did not then see the breakdown of the director's views, which revealed how wide the division of opinion
I'd forgotten that I'd earlier agreed with us, yes. Anyway, I obviously had.
And then you say, subject to any last-minute views by Lord Glenarthur, you're content to proceed on that basis. And then third paragraph, you say, let me know what day is chosen to launch this. Everyone will, I'm sure, keep a close eye on the tone of all our statements. And then you ask...
Sorry, where are we
I'm
now?
so sorry. So it's the second paragraph that you see on the screen. Let me know what day is being chosen to launch this. Everyone will, I'm sure, keep a close eye on the tone of all our statements. And then you ask for a background briefing on the state of play on research into AIDS. Why is so that I've just shown you that not because I have a particular question, but just to complete the picture. Why, as Minister for State for Health, were you involving yourself in the detail, not just of the content of the leaflet, but its method of distribution?
To avoid panic breaking out, encouraged by silly season stories in the newspapers, the panic I was particularly concerned about was anything that put off people volunteering to be blood donors and anything that caused patients to be reluctant to take blood transfusions. Also, as a secondary consideration, I didn't want to feed homophobia. So I was quite content. We obviously had to put out all this, and we had to try to stop gays, promiscuous gays, as it puts it, in particular, giving blood. I seem to have queried that right at the start, but that seems to, I imagine, took about a couple of minutes to sort out. I never could, the meeting ended agreeing we had to do it. But that is the only reason I intervened, and the reason I'm making this fuss about how it's presented and handled is because the only way we could minimize the risk of damaging panic that would have done harm to the service, harm to some patients, was to try to handle it as carefully as possible. That's why I intervened. That is quite obviously from the documents the point I was making whenever there was a meeting.
Now, the issue of and the need for a leaflet had actually been identified back in May, although you were not involved until the beginning of July.
That, yeah.
And so overall, it took from May of 1983 to the 1st of September, when the leaflets were distributed, or began to be available for distribution, to get the leaflet out there. Does that strike you as too long, Lord Clarke?
Well, the shorter the time, the better, obviously. I don't know anything about the actual mechanics of producing and distributing the leaflet. We had agreed to distribute it. I think one of the meetings I was at, there's nowhere where it's not agreed. It seems to be agreed almost straight away that there should be a distribution of the leaflet. And the meeting at the beginning of August, I had agreed to the distribution of the leaflet. What happened to cause delay between then and September, I don't know. But it's not. I agree. Every day was quite unusual, but by the standards of producing a government publication, it's not that long. And this was important to two matters. The most important importance of this leaflet was it was going to make our supply of blood safer and reduce the risk to haemophiliacs and others. And the second most important thing is it should do so in a way which didn't cause collateral damage to the blood transfusion service as a whole. It's quite easy to set off very harmful consequences if you clumsily announce things which are of interest to the press, which AIDS always was, because it's a sexually transmitted new frightening disease.
Do you think your intervention contributed to the delay?
No.
So I note the time.
Because it turns out that the regional transfusion directors, obviously some of them very, very strongly, I'd forgotten that. You'd reminded me that by showing me the last document. So there were divisions of opinion.
So I'm going to move to the second leaflet issue in 1984, so perhaps best on after lunch.
Yes, it is. So we'll take a break now until 2:05. 2:05.
Lord Clarke, I'm now going to pick up the thread of what happened in relation to the second AIDS leaflet. So you'll recall from the documents you've looked at and the discussion before lunch that the leaflet was issued on or around the 1st of September 1983, and the plan was a 3-month trial, which would take one to the end of November 1983. Now, I'm going to ask you to look first at a document that you would not have seen at the time, just to help fix what was going on. DHSC 0002239_015. This is a minute dated the 14th of February 1984 from Dr. Alison Smithers, who was a medical officer who had replaced Dr. Wolford, to Mr. Williams. And it says in the first paragraph, "We have briefly discussed the need for the current AIDS leaflet, which is distributed by regional transfusion centres to potential donors. In view of the published evidence of transmissibility of AIDS by blood transfusion, our current advice to donors could seem too lax. It may also be necessary to take up with the transfusion directors the need for more positive distribution rather than the negative approach that some of the centres have used." So you'll see there, Lord Clarke, Dr. Smith is raising issues both about the content of the leaflet, the advice it gave, and the method of distribution.
Yes, he wanted to toughen up the advice as knowledge all the time was steadily improving.
Toughen up the advice and revisit the question of distribution.
Revisit distribution, yeah.
Now, as I say, you wouldn't have seen that at the time, nor I think would you.
And this is February 1984.
1984. The first submission on this issue, which appears to go to ministers, including yourself, is in August of 1984. DHSC 00023009. Oh, I'm so sorry, Chairman. 2309_044. Sorry, I can't read my own handwriting. So you'll see the date on this, Lord Clarke, is the 10th of August 1984. It's addressed to Mr. Joyce in Lord Glenarthur's private office, but if we look to see who it's copied to, is it right to understand that Miss Bateman was in your private office?
Certainly.
And we can see, if we go back to the first paragraph...
That doesn't necessarily mean I saw it,
No.
does it?
No, but in terms of getting to your private office... sorry, well, I'll read it and then we'll look at what's written in handwriting at the top. So paragraph 1, I attach a submission from Mr. Williams which seeks ministers' agreement to the revision of the current AIDS leaflet. I agree with the action recommended in paragraph 10. In addition, ministers may wish to know that we're likely to require up to 1.5 million leaflets, which can be printed at a cost of approximately £15,000. This can be met from within Information Division's budget in the current financial year, although this is likely to lead to the postponement of more routine publicity in relation to the National Blood Transfusion Service. Officials believe, however, that it is vital that the AIDS leaflet should be reproduced and that it should be accorded this priority. So would you agree that last sentence is stressing the importance and perhaps the urgency of
Yes, it's taken from February when she was recommending it to August to get here. Does that mean they've been drafting it?
I'm afraid we don't yet fully know exactly what was
Well, it's difficult
happening.
to know anything about any of the things if there isn't a document about it, isn't it?
No, there's nothing to suggest that any material in the intervening period came to you or Lord Glenarthur, at least nothing of direct relevance. If we look at the handwriting at the top of the page, however, you'll see it says MSH to C, 13th of August.
Well, because of my interest in the previous one, I obviously thought I should be shown this one.
Yes, so that would suggest that someone in your private office has decided...
Knew I'd been interested in the subject before, yeah.
Now, if we go over the page to the leaflet, to the submission itself, paragraph 1 explains that this submission reports to ministers on the experience of the initial issue of the new leaflet, AIDS and how it concerns blood donors, and seeks permission to issue a revised version. The submission also suggests a more uniform and consistent distribution system to be adopted by regional transfusion centres in England and Wales. And then if we go to paragraph 3, paragraph 2 sets out the background, which we covered before lunch. Paragraph 3 says the current AIDS leaflet, flag A, is now out of date in certain detailed factual matters. And there is a need to strengthen...
Just to interrupt you, this underlining and all the rest of it is in the sidelines. I think they're mine.
So this may be an indication of one of those few documents...
It's one I have seen. That you can see the sentences that I've highlighted.
Yes, thank you. So you'll see there is a need to strengthen its warning. So someone, maybe you, has underlined out of date and strengthened its warning to high-risk groups not to donate, and then reference is made to the redrafted leaflet. And then if we go to the next paragraph, results of review, results from the monitoring exercise at paragraph 2 above, that was the the trial period in relation to the regional transfusion directors, indicate that the distribution of these leaflets has not caused any fall in the number of blood donors, and that there's been little, if any, adverse comment by donors. However, there was, as anticipated, a wide variation in the manner in which the leaflet has been distributed by the regional transfusion centres. At some centres, all donors were sent the leaflet individually.
Yeah, and I have sidelined and put an arrow to the letter which showed that my fears had not been borne out. We hadn't seen a fall in the number of blood donors. There's been little or no adverse comment. So I obviously felt I was reassured by that, and I put in that particular squeal arrow thing, showing that that was good news.
And so just continue with that, all donors at some centres, all donors were sent the leaflet individually with their recall notifications. Others offered donors the leaflets to read when they attended a donor session, whilst a few centres pursued a policy of having them available for donors to pick up as they wished. Paragraph 5 is headed "The continued need for a leaflet." The slow but steady increase in AIDS victims in the UK, 51 cases with 28 deaths up to the 30th of June 1984, indicates that the disease is prevalent here. Haemophiliac patients are at greatest risk of contracting the disease, since the clotting agents they need are produced from plasma pooled from a large number of donors. Fortunately, of the UK patients receiving treatment for haemophilia, only 2 have become victims of AIDS, and both had received factor VIII concentrates from United States sources, as well as the UK. It is known that one...
And his donations were eliminated. So by this time in 1984, we'd had 2 haemophiliacs become victims of AIDS, and they both received American factor VIII, and we only knew one blood donor who got AIDS, but his donations have been traced and eliminated. So that's where we were by then.
And the submission continues, "It's therefore clear that there continues to be a need for positive action to ensure that donors who may be carrying the transmissible agent for AIDS are dissuaded from giving their blood until a screening test suitable for detecting possible carriers has been..."
So that we know that any delay in issuing the first leaflet had no effect on anybody's health at all.
Well, I don't know whether it can be said that
Yes, we
that's
do.
known more generally, Lord Clarke, but in terms of the information...
We know that exactly, because the earlier leaflets were not responsible for the only 2 that got AIDS, because they both had American concentrates. Now we can be confident that was the source of them, though then it wasn't so sure. But we only had one. Obviously, the only one that was traced was a blood donor, and he'd been eliminated. So we know that the first leaflet had not caused any adverse effect to anybody's health.
I would be very happy to have drawn that conclusion, but for one thing, that this is looking at AIDS. It isn't looking at the infection.
I quite agree. Hepatitis is more...
Well, not hepatitis. This is actually HIV infection, because the part of the evidence which the inquiry has heard thus far is that there are these stages. That there is transmission to infect somebody, but it may well be a matter of 2 to 4 years before the individual so infected shows clinical signs which are identified as AIDS, AIDS being a manifestation of the serious effects on the immune system caused by the virus. And so it's impossible to say how many people may have been infected unknowingly by having had a blood transfusion who might not have had if somebody who happened to be a practicing homosexual didn't themselves know they were suffering from any infection. Actually,
I will concede that in the 5 weeks between the first leaflet being proposed and it going off to the printers, it is conceivably, faintly possible that such a case had occurred.
If we continue with paragraph 6, officials consider that the departments would be open to criticism if, top of the next page, it failed to take all reasonable practicable steps to discourage all high-risk donors from giving their blood. It is suggested that all those RTCs who did not send out the leaflet individually to their registered donors should now be asked to do so at the next recall of those donors. This has relatively minor cost implications for some RTCs. and those are then spelt out. And then if we go further down the page, I don't need to ask you to look at the reference to other developments. We go to recommended action. Officials recommend the issue of the revised AIDS leaflet for blood donors and a more consistent method of distribution. Decision, ministers are asked to agree to the revision of the leaflet as at flag B, a more consistent and uniformly effective distribution system being adopted as per paragraph 6. So you'll see, Lord Clarke, that you and Lord Glenarthur were being asked to confirm both amendments to the content of the leaflet and now a consistent method of distribution in terms of going out with the call.
And this blood products leaflet has come to me because I had involved myself in the discussions on the previous one, and so as it's a perfect illustration, I personally wish it would make it much easier for me if for more, unless I saw hardly any of these documents, that I obviously read that and received that, because that's a classic. That's exactly how I used to mark them up every time I got them.
And I don't think we need to go to it, but Lord Glenarthur responded on the 21st of August, accepting the recommendation. In terms of your response, if we go to DHSC 0002309_050. This is a minute dated the 16th of October 1984 from your private office, Mr. Naismith, to Mr. Williams. We spoke and I confirmed that MSH has now seen your submission of 8th August under cover of Mr. Parker's minute of 10th August and is content for the leaflet to be revised and distributed in the way in which you suggest. I am sorry this has taken so long to clear. At this distance of time, Lord Clarke, are you able to assist with why it's taken so long?
I have no idea. I'm sorry to see that, because I have no idea. August, if it was sent on the 8th of August, because of my usual habits, it's a possibility it was sent either when I was about to go on holiday or when I was on holiday. I used to go abroad on holiday. It was the only way I could ever really have any family life at all. I used to stop making jokes about my wife being a one-parent family. Any luck, I'd see something of my children at weekends. So I did used to try to vanish for most of August somewhere abroad and just leave work behind. I really have no idea now. It's only I read it as you read it, and I can offer no explanation. Don't know why it took till October before my office were able to send this.
In fairness, actually, I think there's a handwritten note I should show you. DHSC 0002309_046.
Just before we go there, the transcript has wrongly got the date of the 16th of August for this. It was 16th of October, wasn't it?
16th of October is the document we just looked at, yes. So, Shami, could we thank you? So, this was Lord Glenarthur's confirmation of his accepting the recommendation in the submission, 21st of August. But if we just look at the handwriting at the top of the page, it says, MSH, please see the submission attached. Any comments, content for the leaflet to be revised as suggested, and then the date.
And that was put to me on the 14th of September.
So, quite what happened between the middle of August and the middle of September remains, I think, a mystery.
I have no idea. This is all. I would say I'm just like you, reliant entirely on the documents.
But this would.
And I see on the document first sent on the 21st of August, I've written "go ahead and order it" with the date notes to that below that.
If we just go back to.
There we are. I obviously, okay, go ahead. You see that at the bottom? That's my writing. Okay, go ahead. I didn't seem to have cleared it till the 14th of August.
But you're not, 14th of October?
Or 14th of October.
Do you accept that given what was said to be the need for this to be dealt with as a matter of priority, I'm paraphrasing, not quoting there, that even if the delay is from the middle of September to the middle of October, that is a unfortunately long period of time?
Well, the wisdom of hindsight, yes, it is unfortunate. I have no idea. I have no idea what else was going on in September and October. Why? It's exactly a month, isn't it, from the It was put to me on the 14th of September, and then I cleared it on the 14th of October. And I don't know what was going on in that month. There may have been some wild excitement about something else, but even then, I just can't explain that. Don't know.
Now, I just want to pick up with you what then happened, because as a matter of fact, the leaflet, the revised leaflet, I think ultimately goes out under a press release under cover of the 1st of February 85. So we need to now follow through what happened subsequently. We start with DHSC 0002309_053. This is a minute from Dr. Smithers, dated the 19th of November 1984, to the Secretary of State's private office, so Mr. Fowler. Secretary of State has asked for a note summarising the current situation on AIDS. The attach has been prepared with the help of medical colleagues and administrative colleagues in Med, IMCD, CHD and HS1. And we can see in terms of who it's copied to, it includes Ms. Bateman from your private office. If we go over the page, there's a document entitled Update on Recent Developments on AIDS, and you'll see, amongst other matters, paragraph 1 refers to news from Australia that 13 people, including 3 babies, have died from AIDS after receiving a blood transfusion has caused nationwide concern in Australia. And then paragraph 2 refers to a haemophiliac patient in Newcastle contracting AIDS who died at the beginning of the month. And then if we go to the bottom of the page, the question is posed, what's being done to prevent AIDS being transmitted by blood or blood products? And reference is made to the leaflet. And that's obviously the first version of the leaflet. Bearing in mind this was a briefing note for the Secretary of State, do you think it's likely that you would have seen it?
It's perfectly, I just don't know, but it's perfectly possible, yes. I think if it's generally over, yes, it's very, very likely that I saw it, but I can't remember it. I mean, again, I obviously haven't seen this copy of it because it hasn't got my underlinings on. I just don't know whether I saw it or not, but quite perfectly likely.
And then if we go next, please, to a document that was also copied to your office, DHSC 0002323_014. Now, this is a minute dated the 22nd of November 1984, and it's from a Mrs. Hewlett Davis in the Information Division. We can see that it is copied to, again, Miss Bateman, so copied to your private office. And if we go back to the text, you'll see that she says, I attach a revised version of the leaflet drafted by my publicity branch, also attached for purposes of comparison of the original leaflet and the first revised version. I endorse your view that the first revise had to be looked at again in the light of recent developments and ministerial statements. The need is for a much more strongly worded leaflet and for urgent approval, production and distribution. I think our draft meets the first need and should be grateful for your support in getting the quickest possible clearance.
And this is November.
This is November. Now, Lord Clarke, I'm not going to ask you to look at and compare the various draft versions of the leaflets, but what you'll see, and it's just to help understand the chronology of events, is that the previous leaflet having been drafted, approved by Lord Glenarthur, approved in August, approved by you in October. In November, a revised draft is put forward by the Information Division. If we then go to DHSC 0002309_058. I'm not looking at every single document on this path, but I think this helps us understand where we get to by early December. 3rd of December 1984, from Dr. Abrams in Med SEB to Mr. Naismith, so your private office. MSH, that's you, cleared the revised leaflet for blood donors on the 16th of October. We looked at that a few moments ago. And subsequently agreed to delay the printing of the revised leaflet until it could be discussed at the meeting of the Working Group on AIDS on the 23rd.
I was asked to delay it so this Working Group on AIDS could see it.
Yes, and I'm not going to take you through unless...
I don't know who the Working Group on AIDS were, but some expert group.
Yes, I mean, I can take you to it if need be, but I think it's probably not necessary for the purpose
I don't think I have
of
any.
the questions I need to ask you. And then you'll see in the next paragraph, at that meeting, members had only minor comments to make on the current draft, which are appended. They considered that the information in the leaflet was sufficient to give adequate warning to donors in the risk group for AIDS and would not deter other volunteers. It was not thought necessary to adopt a stronger line, as has been suggested by Information Division. So if MSH is content, arrangements can be made for printing the leaflet and for distributing it to regional transfusion.
Well, the whole thing by this time had been receiving massive publicity, hadn't it? So there couldn't be many people with homosexuals or otherwise who had not read in the newspapers all this about the possibility that gay blood was killing people, as the newspapers were unhelpfully putting it.
Well, you'll see from this in any event, Lord Clarke, that by this point in time, 3rd of December, there are effectively these two competing drafts. The draft is originally sent in the summer and the Information Division's draft. And that'll become apparent in a moment.
Right.
But that's, you're being asked on the 3rd of December if you're content to proceed essentially with the draft that you'd previously approved in October. If we then go to DHSC 0002309_060, this is a minute dated the 14th of December from Mr. Harris in the Health Services Division to Ms. Bateman, so to your private office. I believe Mr. Alan Williams has already spoken to you about the above. A revision of the present leaflet approved by the Department's Expert Advisory Committee was sent to MSH under cover of Dr. Abraham's minute of the 3rd of December. That's what we just looked at. 3. A revised leaflet for blood donors is one of the government's announced responses to the AIDS problem. It is therefore highly desirable that action on this is taken forward in the near future. Is that effectively the civil servants chasing your private office for a response?
Yes, it is.
And then if we go to DHSC 0002327_127.
They're chasing up again.
Yeah, I don't think that's this is the first page, please show me. Page before that. Thank you. So this is a minute of the 20th of December 1984. Refers in paragraph 1 to a note giving information about recent publicity on AIDS transmission, Chief Medical Officer's, in the press today, Chief Medical Officer's interviews with the media and his press statement, and seeks MSH's urgent clearance of the revised text of the leaflet AIDS and how it concerns blood donors. Paragraph 2 then refers to a Guardian report describing cases where blood donation had resulted in a 78-year-old man and a mother/baby becoming seropositive to HTLV3. And then there's a suggestion in paragraph 3 that there were factual inaccuracies in that which have been corrected by the Chief Medical Officer. And then 4, these developments re-emphasise the need for the Department to produce the revised version of the leaflet. The National Blood Transfusion Service cannot be asked to effect a more positive distribution of these leaflets until ministers have approved the text. MSH's approval of the revised text, as set out in Dr. Abraham's minute of the 3rd of December 1984, is sought urgently. So you're being chased again, effectively. Is that correct?
Yeah, they're chasing me up again.
And then, as it happens, that may have crossed with the document at DHSC 0002309_062. So this is the same date, 20th of December, from your private office to Dr. Abraham's. And it's a response to Dr. Abraham's minute of the 3rd of December. MSH has now seen your revised version of the leaflet, AIDS and how it concerns blood donors, together with the Information Division version. So you've looked at both drafts, essentially. His initial reaction to both was that we may need to look at some of the assurances again in the light of the publicity surrounding the 2 cases involving blood transfusions. On presentation, MSH saw nothing wrong with your revised text, but felt that the language of the ID, that's the information division.
That was the stronger one of the
Yes,
two, wasn't it?
yes, version conveyed the message more effectively. Should be grateful, therefore, if you and your medical policy division colleagues would cooperate with the information division in producing a third and hopefully final version of the leaflet based upon the ID text to take account of any recent significant developments and amended as necessary to ensure medical accuracy. I appreciate the need to produce the revised leaflet as soon as possible. However, I understand that the forthcoming Christmas break will inevitably delay printing until the new year. That being so, I should be grateful if you could ensure that MSH has an opportunity to comment that should probably be on, the agreed version before printing and distribution goes ahead. So you have, it would appear, responded by having looked at both, asking the various branches involved to put their heads together and produce a third and final version.
When I responded, I thought there was nothing wrong with the revised text, but preferred the stronger one, and would like to just the opportunity to comment before printing and distribution goes ahead.
And then if we look at DHSC 0002339_063, this is a minute dated the 21st of December 1984, so it's the following day, from the Information Division, R. Windsor, to your private office, Mr. Naismith. And it says, in light of MSH's comments, we've reconsidered the text of this leaflet with colleagues from Medical and Health Services divisions. The further revised text is attached. Now, again, I'm not going to look at the detail of the changes.
No, they've made some more changes as well.
Yes. If we just go and look, first of all, at the top of the page, the handwriting, this is someone, it would appear, bringing it to your attention on the 21st of December. MSH, an agreed version is now attached. Content for this to be printed ASAP, question marks. That's the question, I think, being posed to you. Is that your handwriting at the bottom of the page?
That's not. This is.
Yes.
That's my writing.
Yes. You say, is it still true to say that there is only a remote chance of anyone getting AIDS for an ordinary blood transfusion, as it says at the top of page 2, I think that it is?
That's the saying, is it still factually accurate?
I remain wary of appearing to promise blood screening tests and heat treatment. I would therefore like to leave out the paragraph at the bottom of page 3, and then you set out a quote, otherwise okay. So that was your response to the...
That's obviously my response, yeah.
And then we can, there is, as a matter of fact, I don't think we need to go to it, on the 3rd of January, there is a minute that goes back to your private office addressing each of those points.
And what do they say?
It is at, let's just have a look, DHSC 0002323_088.
I mean, the first is a factual question, and then the second is...
I'm happy to look at this for the sake of completeness. It's from Health Services Branch.
It's medical literature change, yeah.
Paragraph 2, MSH's first query about the remote chance of getting AIDS, etc. This statement is medically correct and has been left unchanged.
Yeah.
Paragraph 3, MSH asked for paragraph what is being done to be omitted. The substantive issues on blood screening tests and heat treatment will be considered in the near future, but not quickly enough for conclusions to be put into the leaflet as soon as
they acted on the second one.
We've therefore deleted. And then there is reference to another query that wasn't a matter that had concerned you. So that's, I think...
So there are other things being looked at as well.
Yeah.
And they've decided which countries to refer to and various other things.
Exactly.
Things which I had not raised.
That's right. That's the 3rd of January. And then we can see, we go to DHSC 0002309_065. There's a submission to ministers on the same date, 3rd of January. Ministers have agreed that as a matter of urgency, the revised leaflet should be reprinted and that it should be distributed.
So the final agreement was the 3rd of January 85.
Something like that, yes.
Well, it's dated that.
Yes. There's a further step which is described in this minute, which we see at paragraph 2. I should be grateful for ministers' agreement to the issue of the attached draft health circular, which asks regional health authorities to implement this decision. So ministers were being asked to approve that the leaflet would go out under cover of a circular to regional health authorities. Can I just ask you to look at the top of the page? There's a reference there, Mr. M.A. Harris, and then someone's crossed out, agreed 4th of January 85.
That's not me.
That's not you, no, that's fine, that's all I wanted to check. So I don't think we know exactly when you agreed to this, but
Sorry?
The press release in any event...
Well, I had agreed by the 3rd of January.
Yes. Sorry, forgive me, Lord Clarke, I should make myself clearer. I don't think we have a document which shows your agreement to paragraph 2. I'm not...
Well, that was just just a text of a circular.
The health circular, yes.
I mean, that wouldn't...
But in any event...
Nobody would get very excited about that, would they?
In any event, that brings us to DHSC 0004764_111. 1st of February 1985. Kenneth Clarke, Minister for Health, today announced
it at the end, did I?
publication of the revised leaflet, AIDS, Important New Advice for Blood Donors, and has asked regional health authorities to ensure that it's distributed individually to all blood donors. Mr. Clarke said the new leaflet is more explicit than the previous version. It lists those at risk from AIDS, practising homosexual and bisexual men, drug abusers, both men and women who inject drugs, and the sexual contacts of people in these groups, and stresses that donors in the risk groups must not give blood as they may unknowingly be carriers of the AIDS virus. The leaflet also reassures donors that they cannot contract AIDS or any other disease from giving blood because all the materials used for collecting blood are sterile and are only used once, so donors not in the risk groups can safely and should go on giving their blood.
That sounds as though it is the original and the press office version, because that's very plain and explicit, isn't it? All that.
Again, we've got copies of the leaflet as published, and I'm not going to ask you about the differences in text. But you'll have seen from the documents we've looked at, Lord Clarke, and again, you refer to them in your statement, that it's effectively taken from the end of the 3-month trial, which would have ended at the end of November 1983, it's taken until the 1st of February 1985 for the revised leaflet.
Sorry, what's the 3-month trial?
In relation to the first leaflet, you'll recall there was a trial of how it would be distributed, left to the discretion of regional...
So that had been issued, yes.
So that 3-month trial would have ended approximately end of November 83 or the very beginning of December 1983. It's not until the 1st of February 1985, as you'll see from the documents.
Yes, but the first suggestion that factual knowledge has moved on, and the first suggestion that we were actually identifying cases which looked as though they were catching it is much later than the trial. That doesn't arise till sometime in 1984. It is taking too long. I think it's from just listening to you now, it's from something like July 1984 to this date. Going back to that Dr. Smithies.
That's February.
That's February, is it? When Dr. Smithies first started saying we need a new leaflet.
Yes.
So there we are. I'm sorry. It's taken the best part of a year. I agree, which is too long. Too long.
And in terms of your own involvement, which began, your direct involvement effectively began through the submission going to your private office in August of 1984, we've seen a delay of a month between the middle of September.
The month does seem to be either my private office not putting it to me properly or me dealing with it. But presumably I thought I needed more time to read it or something. Or it may be for some reason there was all hell let loose somewhere else, and the private office kept saying they couldn't put it, they got other things I got to deal with, it got to be dealt with tomorrow. But that month, I agree, does seem to be me and my private office.
So, and indeed you had to then be chased in December, although the period of being chased is a shorter one, on 2 occasions for a response.
Yes, and me, other people as well as me were suggesting last-minute changes, yes. but otherwise we were all approved.
So would you accept a share of personal responsibility for the delay?
Yes. Yes, I think. I mean, what I've just commented on. I can only go on the documents as you can, and at this distance of time, almost 40 years later, I can't remember and don't know why it was a month between it going to my private office and being told it was urgent and me replying. I hope that didn't happen very often. The full delay from February to January of next year. I don't take responsibility for all that, because I have looked at documents before, but I don't remember all these. But, I mean, practically everybody had a view on it. There were all kinds of parts of the department and other groups that were putting in views, I seem to recall, and somehow we just took on board too much discussion.
And given that this was one of the few measures open to the department to protect the safety of the domestic blood supply, that year was far too long, was it not?
Well, the main problem we had was the American blood supply. Have we ever found any evidence that anyone got AIDS from the British blood supply? We have we? And I quite agree with, as the chairman has said, that I mean hepatitis is probably difficult to get more exact figures because people get hepatitis still. But
if we leave aside,
it's a pity that it took so long. I've already agreed it should have taken a shorter time. But again, I don't think we'd yet reached the full extent of the tragedy, which no one foresaw. The real numbers started coming later. We're getting small but serious numbers of people getting infected, and it's too long. And if I contributed to it, and I can't now, all these years later, explain why it was a month between submission to me and returning it. Well, there we are. I accept my share of that.
now, I want to move now to some of the other decisions that were being taken in the course of 1983, or views that were being expressed in the course of 1983. So if we look first of all, please, Seamus, at CBLA 5043_040. Now, this is a document which there's no evidence to suggest it came to you, Lord Clarke. It's dated the 9th of May 1983. It's addressed to Dr. Ian Field in the DHS.
And it's from the Public Health Laboratory Service.
It is. It's from the Communicable Disease Surveillance Centre. And if we look to the bottom of the page, it's there signed N.S. Galbraith. That's Dr. Nicholas Spence Galbraith, who was a leading public health doctor in the Communicable Disease Surveillance Centre in Colindale. And you'll see in the text of his letter is, last week while you were away in Geneva, a case of AIDS in a haemophiliac in Cardiff who'd received USA factor VIII concentrate was reported. The case fits the recognised criteria for the diagnosis of AIDS. In the Lancet of the 30th of April, 3 cases in haemophiliacs in Spain are reported. I have confirmed that they received USA factor VIII concentrate. In the same issue of the Lancet, the tally of 11 reported cases in haemophiliacs in the USA is recorded, and a paper describes a case in a multiply transfused child in the USA. I have reviewed the literature and come to the conclusion that all blood products made from blood donated in the USA after 1978 should be withdrawn from use until the risk of AIDS transmission by these products has been clarified. Appended is a paper in which I set out my reasons for making this proposal. Perhaps the subject could be discussed at an early meeting with haematologists, virologists, and others concerned, so that a decision may be made as soon as possible. And if we go over the page, we'll see the paper that Dr. Spence Galbraith referred to under the heading Action on AIDS. He says that this is...
And what date is this?
9th of May 1983.
83?
83. And he says this: the temporary withdrawal of all blood products imported from the USA made from blood donated after 1978 is proposed until the risk of transmission of AIDS becomes clarified. And then he sets out a number of reasons, and I'm not going to read all of them aloud.
No, you've read. I see them.
Yeah. So I'll just, for the benefit of those watching.
He was suggesting the end of factor VIII.
He was suggesting a temporary suspension of
Stop
factor VIII.
treating patients with factor VIII from America.
He was suggesting American concentrate should no longer be used for a period of time.
But that would have been a very high proportion of our cases.
Yes, and so if we just look very briefly at his reasoning, one, the AIDS epidemic in the USA is probably due to a transmissible agent. 2, the agent is probably transmitted by blood and blood products, and he goes on to give further detail in relation to that.
He turns out to have been quite correct.
He does. 3, although this number of cases of AIDS associated with the administration of factor VIII concentrate is very small in relation to the number of individuals receiving the product, this may not indicate that the risk is small, And he goes on to explain why. And then if we go over the page, you'll see at the top of the page, one of the reasons is the incubation period between potential infection and that the symptoms manifest.
I hadn't realised incubation period was that long.
Well, that was the point I put to you just.
I hadn't previously known that. I had no idea it could take 4 years before it turned up. No, I don't think I've ever heard that before.
Well,
And this is some chap in the Public Health Laboratory Service.
This is Dr. Spence Galbraith, who was a leading figure in the communicable disease surveillance. Paragraph 4, factor VIII concentrate and pool products would appear to have a high risk of being contaminated with AIDS agent because homosexuals and drug abusers, this is now referring to America, are known to be frequent blood donors, and each plasma pool from which it's manufactured is collected from as many as 1,000 donors. That's probably, in fact, an underestimate. But, furthermore, it's possible that the AIDS agent may be present in blood of healthy persons for several months before onset of symptoms.
Yeah, that's all interesting.
5, there is apparently no means of ensuring that blood or blood products are free of the AIDS agent. And then 6, the mortality rate of AIDS exceeds 60% 1 year after diagnosis and is expected to reach 70%. So those were his reasons for the step which he recommended. Now, Lord Clarke, there's no evidence to suggest that this was drawn to the attention.
Well, I don't think I
any
have seen.
minister.
I don't think I've ever seen that in my life before. It turns out to be a very perspicacious man. So he quite rightly suggests that this would be discussed by virologists and haematologists. So what was the outcome of the discussions with the other people with different disciplines who had a look at it?
Well, Lord Clarke, there's no particular evidence of his paper actually being discussed by anybody.
Really? Who was it sent? Who was it sent to?
Dr. Field in the department. There are memos between Dr. Field and Dr. Walford, but in terms of the broader discussion contemplated by Dr. Spence Galbraith, that does not
So what
appear
did Field and Walford decide to do with it?
Well, I'm afraid, Lord Clarke.
Sorry, you're going to find out. It's probably more for the chairman
exactly.
to find that out than it is for me. I'm just intrigued because it is pretty startling stuff. Of course, we're sitting here with the benefit of hindsight. We happen to know that this opinion produced by somebody in '83 from the Public Health Laboratory Service, we can now say, was spot on. I mean, 110% on. This is the kind of thing, if only we'd all known that in early 1983, we'd have saved thousands of lives. So I'm just amazed to read a document which is so perspicacious. He had spotted all this, as we can see from the other documents, long before other people had picked it up or were taking this line. It's a very strong document. And again, as it happens, we now know he was spot on.
Would you agree that this is material that should have been seen by ministers?
Well, I'm surprised that it never got to me, yes. Sort of, I mean, given there are all these arguments going on about how strong the warning should be, I mean, this guy's opinion is certainly superior to that of mine or the press office or people like that, which I've always said my clinical judgments are valueless. I mean, but yes, it is. To me, it is quite startling to read that somebody in the department somewhere had got unless I don't know who he is, unless for some reason they dismissed him and thought he was a strange outlier.
No, he was a very reputable and very well respected.
Yeah, no, there we are. No, it's surprising that. Did Simon see it?
No evidence it went to Lord Glenarvan.
Simon didn't see it either. I find that surprising. I'm sure I would have read it. Some startled. I mean, you can't read it without being rather startled by it.
And I'm asking a hypothetical question here. I appreciate many years after the event, but had you or one of your ministerial colleagues have seen it, you would at the very least have wanted to consider its content and explore whether this was a step or whether there were other steps.
If I saw that, my reaction, I know I'm sitting here now with the wisdom and admittedly, appearing as a witness, so it's quite easy. I would have reacted to that, I think. I would have said, didn't we agree with this? What is the opinion of are you getting, expert comment on this and so on? Because it is pretty stark and startling. Once they'd reassured me this bloke isn't some crank, that he's again, I've got to be careful subliminally, no doubt. I'm influenced by the fact that I see what a complete warning it's been acted on, difficult. So I don't know why that went into nowhere. So I think, being polite, I'm surprised certainly surprised it never got to Simon, but I strongly suspect that if it got to Simon Glenarthur, he'd have made sure his office copied it to me in pretty quick time. And then we would have, if the medical team had said, well, he's of that view, of the laboratory service, but the virologists in the other say X, Y, Z, we can't just get... And the other thing, of course, which at some stage the were all considering, was what he's suggesting is even more dramatic than stopping blood donations by homosexuals. He is suggesting stop treating haemophiliacs with factor VIII. Now, we do have to remember, when we look at the doctor's decisions on that, when they started weighing the balance of risk, once you stopped giving factor VIII, you were killing some haemophiliacs. You were reducing their life expectancy, and their quality of life was dramatically reduced. Now, had we known that almost 3,000 haemophiliacs were going to die from the factor VIII, that should have been taken. But had the decision been taken to stop factor VIII, we'd have faced rage and fury from the haemophiliac community, who would have known that their quality of life was being damaged, that they were being killed, and some of the campaigners would have accused us of overacting and getting panicked to American rumours and so on. Had it worked, we'd probably have continued to be cursed, because no one, had we done it, then 2,800 people, whatever it is, would not have died. So we'd have continued to this day to be reviled for condemning haemophiliacs to going back to the kind of life they'd enjoyed before this wonder treatment was devised.
We'll need to unpick quite a lot of what you've described there, Lord Clarke, but I just want to deal with things in a chronological fashion at the moment.
Well, I'm trying to get to the point.
Well, I hope that the next question will take you to the point, Lord Clarke. The Committee on the Safety of Medicine's Biological Subcommittee did...
Committee on the Safety of Medicine's Biological Subcommittee.
Yes, so it's a snappy name, the Biological Subcommittee of the Committee on the Safety of Medicine.
I didn't know they had one,
Did consider the question of whether they should take action to...
So they considered this bloke's suggestion?
Well...
He was at the meeting.
He was at the meeting, but the evidence the inquiry has received from the chair of that committee suggests that his paper was not the subject matter of discussion at the meeting.
Right, and what did this subcommittee advise?
Well, I'm going to ask you to look at their conclusions now.
Because I don't think I was ever aware of their existence.
You didn't, and that's really the purpose of the next line of questions, Lord Clarke. DHSC 0001208, please, Shomek. This is called Summary of Main Points.
Yeah, I'm just trying to read it. Yeah,
and licensed blood products by CSMB, that's the acronym for the Biological Subcommittee of the Committee on the Safety of Medicines, 13th of July, 1983. And if we look, it says the following conclusions were reached.
Hold on, let me just read it.
Yes, of course. It was sent to you in advance of your evidence.
So you've got a professor of haematology, chairman of the Haemophilia Centre, a virologist, Mr. Belgraith, who'd one of the participants who's the man who raised this percipient minute. The director of regional blood transplant, yes, okay, so it's an expert subcommittee group.
Well, they are in fact not the members of the subcommittee. They made addresses to the subcommittee. Well, they were invited.
Oh, they were the outside expert group advising the subcommittee. My apologies, quite right.
And then you'll see it says the following conclusions were reached. Again, I'm not going to read all of it, but if I just read...
No, I'd quite like to read it, actually, to keep dotting about and putting selected bits up.
Yes, of course. I think you'll find, Lord Clarke, it's material...
Shall we then remove the selected bit and just allow Lord Clarke, to get to the bottom of the page, just tell Schumich.
And then
would
the
you like
next
to move
page.
on?
I'd be very grateful if you could do that, Chairman. Thank you. I don't like this snatching out sentences.
Well, just take your time and let us know when you're ready to move on to the next bit.
So I'm taking a little time because, again, I'm not a clinician, so I have to reread some of this. So I reached the bit, the risk appears to be greatest in the case of products derived from the blood of homosexuals and IV drug abusers, residents, etc. So this, yes. I finished that. The possibility was considered, it's not feasible. I seem to think you could use something called cryoprecipitate, of which I've never heard. That's not feasible. Now, what else did they look at? I've finished paragraph. I've finished subparagraph 3. So the possibility was considered of withdrawing US preparations from the United Kingdom. Now, actually, with hindsight, we know, if we know what we know now, that's what should have been done and would have saved lives. It was concluded that this is not at present feasible on grounds of supply, meaning there was no alternative salt, not enough alternative salt. Moreover, the perceived level of risk does not at present justify serious consideration of such a solution. Efforts are having made, goes on to the attempts we were making to make ourselves self-sufficient. Right, there we are. That paragraph 4 seems to me the key paragraph. They actually did consider stop using imports from the US. All of them, including Mr. Galbraith, came down against it.
No, he wasn't a voting member.
Wasn't a committee member. We must have sat there. We don't know what he argued. Mr. Galbraith may have been dissenting as an expert witness.
We have no information that he was, but
we've no idea.
Have no information.
Well, I imagine half the members of the meeting won't now remember what was said there, who said what. So we don't know. Mr. Galbraith, who was this great and wise man, who had, first man to have spot-on insight of what we'd all like to, have seen happen. Now we know what we know, but he was there, and they listened to him presumably, and all the other experts, and that's the conclusion they came to. Which, again, I'm not being critical. Not remotely critical of people. In the light of knowledge at the time, we can only sit here and say, well, how sad. It's a pity they reached that conclusion, but. I mean, there we are, this little subcommittee nearly really considered with the first. I don't think anybody before that, presumably, had weighed up the competing arguments about whether we should stop using American Factor 8.
Well, it's really one of the questions I had for you, Lord Clarke. There are questions, Lord Clarke, as to what information this subcommittee were provided with, but that's not, and whether it was
that's way beyond me.
And that's not a matter you can help us with. I should just say, if you look at your witness statement, Lord Clarke, at page 86. You did comment on this document in your statement, so I didn't want it to...
I'm sorry, I interrupted you asking, can I please read it?
That's
because
right.
I didn't remember it.
No, that's okay. I just didn't want it to be thought that you were being taken by surprise.
86, you say?
Page 86, paragraph 7.103, you say this... Oh, thank you, Schumich. I've been asked whether the decision of the Biological Subcommittee of the Committee on the Safety of Medicines taken on the 13th of July 1983 was brought to my attention. I have been shown in particular a summary of the main points considered at this meeting, that's the document you were just reading, which shows detailed consideration of and decisions on a range of issues. I cannot remember involvement in decision-making on this issue, but I may have been aware from conversations with others in the DHSS, possibly the CMO, just pausing there, that would still have been Sir Henry Yellowlees, that such issues were being considered by the experts. This would have been a general understanding, however, and I do not think I was aware at the time that this particular group of experts were considering these matters. So that's what you said in your statement, Lord Clarke.
Well, that's actually been drafted by the very good, very helpful Department of Health lawyers who produced the draft, which I went through. This is my evidence. I mean, I'm not getting out of saying that. It's a rather, it comes to the same conclusion. I don't recall ever having seen it or heard it before, but I say my reaction having seen it again, probably because of the context and the fact we've already been over such things, is being a little startled. But that I haven't seen it. But yeah, comes to the same conclusion. I don't think.
And I should say, Lord Clarke, that there's no documentary trail that has been uncovered to suggest that it was brought to either your attention or Lord Glenarthur's.
No, well, normally the biological subcommittee of the Committee on Safety of Medicines, they wouldn't submit things to ministers. Those sort of committees exist that where they do report to is the chief medical officer sometimes. And if he wanted to challenge their conclusion, he might have taken it up. But though again, he probably would accept that they were all more expert than he was, and accepted their conclusion, which they reached, that they weren't recommending any change. But this is a slightly more long-winded way of saying I don't think any of us knew about this.
Would you have expected that a decision of this magnitude, one of the most significant decisions taken in 1983, not to restrict or ban the import of American concentrates, would you have expected that to at least come to the attention of ministers for information?
Well, it's not a decision. I don't think this subcommittee would make the decision, would they? They're not a licensing authority. The conclusion of this group not to recommend it, I suppose what they didn't recommend didn't go to anybody.
Well,
but it's the original paper, the one put forward by the laboratory service asserting this. I am a little surprised that was just left to the subcommittee of the other committee to decide whether to take this up. And, if Mr. Galbraith was disagreeing, if he wasn't persuaded at the meeting of the subcommittee, he might well have decided, well, this was hopeless. He's going to try and get somebody else to listen to him and gone to one of the medical officers or something. So I'm a little surprised. I'm not criticising him. I'm amazed by Mr. Galbraith's insight. But it is, I suppose, not for me to depend on this subcommittee, which I'd not heard, although I've also been shown it before, but I've forgotten that that's what it was called. And I don't think I've ever heard of this subcommittee. But I'm surprised they decided not to act on it, not to recommend it, and not to tell anybody about it and just drop it.
If I can just help on this, my understanding, derived from documents which I've seen, is that the subcommittee, as you would expect, reported to the committee, which met a week later. I think it was the 20th of July, and they normally acted on the recommendations of the biological subcommittee.
So recommendations,
and they gave it a tick.
Yeah, well, you, of course, have heard more evidence than me, and my opinion on this doesn't matter tuppence, but yeah, well, so that's how it was dealt with. And those expert committees, it was only when they required action that they would go, I think, first to they would go first to the CMO to give him their expert advice and leave him to work with the world of Whitehall to make sure that recommendation was acted on. But it obviously died in the subcommittee. And then the committee accepted the recommendation of the subcommittee, which is
yes. I gather that was their usual style, but it was still the committee's decision.
Yeah. But that committee would never report directly to ministers.
Yeah.
Would you, however, have expected that what you described, and I'm paraphrasing, not quoting your evidence here, Lord Clarke, about the need to weigh matters up, consider pros and cons of whether to act or not act. Are you surprised that that's a matter that didn't come to ministers at this critical time?
A little surprised, I am. I mean, the people it did go to, with all these other expert advisors assembled for the purpose, were in a better position to appraise this advice than any minister would have been. But Yeah, I'm a little surprised that certainly Simon, as the minister responsible for blood products, never even shown it. And because the main thing I've got involved in, as you've rightly been questioning me about already, was how we presented their change of policy of collecting blood to the public. But, it might have come to me as well. I suspect Simon would have come wandering into the office saying, "Cracky, have you seen this, Ken?" But then we might well have been reassured, well, other people who do understand this better than you, Minister, have all been over it. There has been a whole meeting of the subcommittee, and they decided that there's no need to act on what he's saying about it. So it probably still have died. But given where I am now, what I know now, given I find myself before this inquiry 40 years later, it would have been interesting to know what would have happened if I'd seen it. Would I have taken off and said, Prime Minister certainly would have asked, what the hell are we doing about this? But they might have reassured me, no, don't worry, the experts have all looked at this and it's decided that Mr. Galbraith takes it too far. And Galbraith may even himself have been persuaded. Although, as it's been pointed out to me, he was not a member of the subcommittee, so he was no part of their decision.
Yes.
But he was at their meeting.
And sadly deceased, I'm afraid. So
anyway, it died in the biological subcommittee of the Committee on the Safety of Medicines.
There's then a slightly separate issue about American imports that I want to ask you about, but can do so most easily from the biological subcommittee's conclusions. So if we go back to DHSC 00012008, please show me. We go to the second page. And we look at paragraph 5. So I'm just going to read this out, Lord Clarke, but you might want to read it while I do. It is advisable that all clotting factor concentrates derived from US plasma sources and intended for use in the UK be prepared only from material manufactured from plasma collected after new regulations were introduced by the FDA on March the 23rd, 1983. That's a reference to the Food and Drugs Administration in the States. These regulations were introduced specifically to minimise the likelihood of collecting blood from affected donors. This step is recommended, notwithstanding the possibility that its practical value may be relatively small. It cannot, however, be taken until supplies of post-March the 23rd material can be assured. It's recommended that close contact is maintained between the Licensing Authority and Supplies Division with the aim of introducing this step immediately it becomes feasible. Lord Clarke, the issue to which that paragraph is alluding reflects the fact that in late March of 1983, the Food and Drugs Administration in the States introduced recommendations about how blood should be collected after that date.
Yeah, but the Americans were as concerned as we were beginning to get and were trying to improve the quality, safety of their Factor 8.
And a concern arose as to whether factor concentrates made from pre-March 1983 plasma, in other words, potentially collected in a way that was less safe than post-March plasma, or less safe, maybe putting it too high, but in any event, collected without the adherence to the post-March regulations, would be dumped on the UK. So the Americans wouldn't want to use it; they'd dump it on the UK. And so a question arose.
So were they doing that?
Well, there is some evidence to suggest that there was a concern about that within the department. So a question arose. Even if the UK was not going to ban all imports, should steps be taken to restrict pre-March imports? That, again, does not appear, as far as the documents show, to be a matter that came before Lord Glenarthur or you. Does that surprise you, that this narrower question of the pre- and post-March concentrates didn't get anywhere near a minister?
Well, again, Simon might have been advised of it, not to the same extent it doesn't, because this isn't suggesting that you stop using the pre-March stuff. It just points out that it is advisable, I mean, highly advisable from what you're telling me. I'd have thought that you should start using this post-March stuff. But it says it's recommended we do that once it becomes feasible. They weren't suggesting stopping anything. They were just, obviously, as quickly as possible, we should make sure we're only using the post-March stuff. I'm not quite sure what the minister would have done if it had been sent to him. What could he do to go along with that?
Well, again, there may be questions.
Unless you're going to stop treating people with factor VIII,
Yes.
which, as nobody came to the conclusion we should do that.
Again, there may be questions as to the basis upon which this subcommittee formed the views it set out in
I would. This would be. I mean, this. Talking about myself, I don't know what Simon said. Whether he wishes he'd seen it. I'd have been rather surprised if something like this got to me. This is getting down to real detail.
But would you have expected this question of whether this concern about the possibility of less safe products being dumped on the UK market and whether any steps should be taken, would you expect that to have been at least notified to the Minister with special responsibility so that he could consider, if necessary, with the advice of the CMO, whether there were any steps he wished to take?
Well, what's this saying should be done? It isn't the paragraph, as far as I can see, isn't suggesting anybody does anything.
Well, I'm not really asking you, Lord Clarke, to construe.
No, but why should it go to Simon particularly? I mean, an awful lot was going to Simon, and Simon was the one day to day in touch with these things. But I don't know whether it went to Simon. Probably nobody remembers whether it went to Simon or not. It doesn't actually recommend any action.
I'm really asking about the underlying issue, Lord Clarke, not the particular formulation that the biological subcommittee came up with. Although they wanted the change to be implemented as soon as.
Well, they're saying it's advisable that we stop using this stuff. So it's recommended that we do so once it becomes feasible. So I'm not sure what Simon would have done with it if it had got to him. I'm sure it was stopped as soon as it became feasible.
Not sure whether there's any evidence to that. Is that what your expectation would have been? That steps would have been taken to monitor its feasibility?
Well, I don't know. Yes, obviously, until you've got some way of being able to identify what was pre-March 23rd and what was post-March 23rd, it was not feasible to do anything about it. So I accept that's what happened. I'm sure that is what happened. That's what it's being recommended here.
Just, Lord Clarke, so that you understand, I'm not trying to debate with you the merits or otherwise of either the step recommended here or what was or wasn't done. It's more the decision-making process as to whether decisions...
There's no decision involved.
As to whether ministers should have been alerted to the possibility of pre-March plasma being dumped in the UK so that they could consider if there were steps they wished to take.
The paragraph says nothing whatever about pre-March plasma being dumped in the UK.
No, there are other materials which do.
Well, there we are. I haven't seen that.
Yes, I think some of them were shown to you for the purposes of...
On this paragraph, it's not recommending any action, and I can't quite see that any action would have been taken if it had been given to ministers or not.
I think, actually, it is making a recommendation if you look at the last sentence.
It's recommended when it becomes feasible.
But yes, close contact is maintained. That's the recommendation. The aim is to introduce this step. It doesn't say what this step is, but I think the implicit step may be, unless someone else has a better interpretation of this in due course, maybe the step to stop taking pre-March 23rd, 1983 plasma. That would need to imply...
But it says you can't do that.
On grounds of feasibility. The feasibility, as I understand it, at the moment, but again, this is subject to further argument and evidence, is that post-March 23rd plasma was labelled as such in the United States.
But what it says is you couldn't stop taking the pre-March 23rd plasma
until it was feasible.
Until you got adequate supplies of the post stuff.
That's probably what feasibility means. As soon as you've got adequate supplies,
then you should introduce that step as soon as it's feasible, which means as soon as you can get adequate quantities of the post. That's my understanding of it. I mean, I don't want to debate it because it says what it says. I mean, the paragraph is perfectly clear. It reads for itself.
No,
It's not suggesting that anybody takes any step apart from as soon as it's recommended that as soon as we can be certain we've got enough post-March 23rd staff, only use the post-March 23rd. And it makes no suggestion that the manufacturers were deliberately dumping stuff on others.
The word dumping is not used. What is suggested, I think, is keeping a close eye on it to see...
Oh, yeah. As soon as we can make sure that we've got enough post-March stuff, use that and stop using the old stuff.
Yes.
Yeah, that's very good. That's what he said. That's really what it means.
So I note the time, perhaps a good moment for a break.
Yes, it would. Shall we take a break then until 4:45?
Thank you, sir.
4:45.
Lord Clarke, I'm going to ask you next about some recommendations emanating from the Council of Europe's Committee of Ministers in 1983. If we start by looking at a minute, that's DHSC 0002309_086. You'll see that this is a minute from Mr. Cumming to, I think, Mr. Patton's private office in part, dated the 2nd of July. But if we look at the top right-hand corner, handwriting, we can see copy to Mr. Alcock and Mr. Joyce. So that's to your private office and Lord Glenarthur's private office. And it says this: from time to time, we submit to ministers international instruments which involve DHSS interests. It is normal practice during the preparation of these documents to ensure that the UK is not committed to policies which would not otherwise be followed, so that there is correspondingly no action to be taken if and when they are adopted. However, recommendations or undertakings in international agreements are often of interest to pressure groups, and it is thought that ministers may wish to be aware of recommendation R83.8, which was adopted by the Committee of Ministers of the Council of Europe on the 23rd of June 1983. And then paragraph 3, the subject of the recommendation is the prevention of transmission of AIDS from affected blood donors to patients receiving blood or blood products. On the basis of present knowledge, it's assumed that AIDS is transmissible by blood, and the recommendation aims to ensure that appropriate precautions are taken in the preparation of certain blood products. And I think that's probably the word "and" or something like that, handwritten, and that specific groups of recipients, such as haemophiliacs, are accordingly reassured. Paragraph 4 refers to an information leaflet used by the American Red Cross, appended to the recommendation for the convenience of national blood transfusion services wishing to draw up their own leaflet. 5, the recommendation does not prevent the UK from continuing to import factor VIII concentrate from the USA, on whom we currently rely for about 50% of our supply. And then 6 refers to attaching a copy of the recommendation. Now I'm going to ask you to look at the recommendation.
And this is July 83.
This is July of 1983. I don't think we have a precise date. But if we look at DHSC 0002309_029, we can see a minute dated the 22nd of July on behalf of Lord Glenarthur to your private office, saying Lord Glenarthur has seen Mr. Cummings' minute of undated July and thinks we should accept the recommendation. He also feels that there might be merit in referring to the European advice when MSH announces the publication of our own leaflet to potential blood donors. Does MSH agree?
Is that to me then? Yes.
Yes.
Do I agree?
You do effectively. So that's the minute to your private office, and then the response.
Sorry, wasn't the recommendation that we stop using American supplies?
No, I'm sorry. This is a different recommendation, and I'm going to come on to the text of it in a moment. I just want to show the dates and who saw it, and then we'll look at the text.
Sorry.
No. So DHSC 0002309_031 is the response from your private office. If we just look at the date, so 26th of July, MSH has seen your minute of the 22nd of July attaching Mr Cummings' submission and agrees that our own AIDS leaflet should refer to the European advice. So it would appear that you saw the minutes and you're responding to what Lord Glenarthur had to say. If we then go to the text of the recommendation itself, it's MACK 40307, please, Shomek. And if we go to the next page, we'll see it's the Council of Europe Committee of Ministers, recommendation number R838.
Is there any evidence that any minister participated in the Committee of Ministers?
No.
Because Britain was and still is a member of the Council of Europe.
There was a British delegate who was in fact Dr. Gunson, who was the consultant advisor, regional transfusion director and consultant advisor.
Yeah, the council. Yeah.
He was actually the rapporteur, wasn't he, for this?
Yes, you're right, sir. Sorry, he was.
And he was a Department of Health guy, was he?
No, he was a regional transfusion director, but he was also had the status of consultant advisor on blood transfusion to the chief medical officer.
And he was representing Britain on the Committee of Ministers.
Well, I don't. He was present at their deliberations and reported back. He wasn't, I think, on the committee itself. I don't think we have to hand information about who was on the committee. In any event, there's the title of it. If we just go further down the page, you'll see the date it was adopted on the 23rd of June 1983. There are a number of preambles about AIDS set out, which I'm not going to ask you about. If we go to the next page, we'll see the recommendations. So it recommends the governments of member states, 1, to take all necessary steps and measures with respect to the acquired immune deficiency syndrome, and in particular, and then you'll see, Lord Clarke, there are 3 recommendations set out. The first is to avoid wherever possible the use of coagulation factor products prepared from large plasma pools. This is especially important for those countries where self-sufficiency in the production of such products has not yet been achieved. And then the second recommendation is to inform attending physicians and selected recipients, such as haemophiliacs, of the potential health hazards of haemotherapy and the possibilities of minimising these risks. And then the third is to provide all blood donors with information on the acquired immune deficiency syndrome so that those in risk groups will refrain from donating. An example of an information leaflet for donors is appended. Now, I'm not going to ask you anymore, Lord Clarke, about the third recommendation because I've already asked you about the AIDS leaflets in 1983, 84, 85. What I want to ask you about is the second recommendation. So you'll see there it's to inform attending physicians and selected recipients such as haemophiliacs of the potential health hazards of haemotherapy and the possibilities of minimising these risks. First of all, Lord Clarke, before we look at the topic of the recommendation, in light of the minutes that we looked at and the fact that this was sent to you, do you think you would have read the recommendations themselves?
Yes, I wouldn't have said we adopted the recommendations without reading them. Yes, certainly.
And broadly speaking, at that time, what kind of importance would the department have attached, or you yourself have attached, to recommendations of the Committee of Ministers?
The Council of Ministers, well, although I have every respect for the body, I was a parliamentary for a very brief time. I used to go to the Council of Europe, but it's a rather obscure body, and the political deliberations and the committees of the Council of Europe, don't have any binding effect. So it's not a high-profile thing. It can be very useful sometimes. It's a good job we're still members of it, but it's not mainstream politics unless you get into it. So this isn't a major international decision-making body, not the Parliamentary Assembly or the Ministers' Committee. In fact, the fact that at the time we seem to have been spending, one of our advisors, obscure medical advisors to it, to actually act as our representative, shows that the title Council of Ministers was a bit high-flung, but I personally regarded it as a useful international forum. When I did it, I was in the Whip's office as well. As it happens, I was a member of the government at the same time as being an MP when I went to the Parliamentary Assembly. I used to find interesting and a very useful way of developing more international contacts and a better way of understanding the politics of other countries and exchanging ideas with people I wouldn't normally work with. That's what the Council of... I mean, there are important aspects of the Council of Europe, mainly the European Court of Human Rights, which is a Council of Europe institution. That issues binding judgments. But this kind of advisory, recommendatory stuff is all right. It's a bit fringe.
It would appear from the exchange of minutes that we looked at, however, that the response within the Department of Health was essentially to accept these recommendations.
Yes, and Simon and I seem to have thought they were okay.
And so if we then look at the second recommendation to inform attending physicians, you'll see from that, Lord Clarke, and let me know if you disagree, it's a recommendation to governments to take all necessary steps and measures to inform two cohorts of people, doctors.
Well, relevancy here, doctors and haemophiliacs.
Yes. And it's to inform them of two categories of information: the potential health hazards of treatment and the possibilities of minimising the risks of AIDS. Now, would you have essentially just assumed, do you think, that was being done because you weren't being asked to take any...
Well, were there any doctors and haemophiliacs who didn't know there was all this concern about American factor 8 and minimising the risks? There wasn't much we could do unless you stopped taking factor 8.
Well, I'm going to explore with you some possibilities. This is...
I mean, you know, there's nothing wrong with the recommendation, but didn't Liverpool know quite what more one could have done on either of them?
Should the department not have taken at least some steps, having accepted the recommendation, to satisfy itself that physicians and haemophiliacs, two distinct cohorts there, were aware of both the risks and ways in which those risks could be minimised?
Well, what the difficulty was, as we've seen from our earlier discussions, that we couldn't find any way of minimising the risks short of stopping using American factor 8. What possibilities of minimising risks could we have possibly told the haemophiliacs about, apart from if they were homosexual haemophiliacs, which is, well, I'm sure some were, to be, you know, try and stick to one partner. Actually, they're heterosexual, because actually heterosexuals get AIDS as well, which we were always anxious to point out in the 1980s to counter the dreadful homophobia that surrounded all this. But I'm not quite sure what possibility of minimising risks we could have put to the haemophiliacs. And I don't think many, because we didn't know the scale of the infection of infertile product, I don't think any haemophiliac would have stopped taking factor 8.
Let's just look at it in stages.
What are the possibilities of minimising the risks we should have put out?
I'll explore that with you in a moment, Lord Clarke. Let's just start with the first part of the recommendation, which is to provide information about potential health.
Well, they were all over the newspapers.
The inquiry has heard evidence from both families, patients, clinicians, which it might be said paint a fairly overwhelming picture of people not having risks drawn to their attention.
Well, they must have been fairly switched off. I mean, you're asking them what they knew 40 years ago in a particular date in 1983, but as you've seen from the early discussions, one of the things that was concerning Norman, not just me, was the outrageous presentation of this problem as far as the general public was concerned. I mean, we haven't got the... I don't recommend you get all the press cuttings, but I mainly remembered of one today because I cited one, you know, gay blood kills donors, and but whilst we still weren't certain, there was no conclusive proof that it did. There was a tremendous mayhem being kicked up. That's why we were anxious to present these things carefully and avoid causing an absolute panic. And there's no point in raising awareness of health hazards any higher unless you're also going to suggest what people do about it. So it's no good going out there. I said, this tragedy is just appalling what actually happened, but what we should have done, just gone out and said, we think it's important in the public interest that we tell you that you're going to die. And then they say, what am I meant to do about it? And we say, I'm afraid we don't think there's anything you can do, because unless you want to stop taking factor VIII.
Isn't the point about ensuring that this cohort of patients were informed of the risks of their NHS treatment to enable them to take an informed decision
about whether to stop taking
as
factor
to whether
VIII?
to take less or take none,
Taking less,
or whether to give it to their child or not?
Well, the physicians, if they were remotely keeping up to date with things, must have been aware that this was a mounting concern. So they all had specialist doctors who were treating them. They didn't just give themselves factor VIII. I don't know. Personally, I have to admit, I don't know how you take factor VIII. So I apologise if, in fact, you're given a pill which you take home. But they all had highly specialised physicians treating them. And physicians, unless they were getting woefully out of date, must have been fully informed, better informed than I am, about what they thought the risks were. And some of them may have shared this with the patients, but again, the physicians would take the view, what is the point of scaring the patient if one doesn't quite know what you're suggesting to the patient they should do? You're saying, well, they should choose whether to take the treatment or not, but the factor VIII made such a difference to the quality of life and the life expectancy of haemophiliacs. I can't, and they would have, the consequences of stopping taking factor VIII were very serious for them. I find it difficult to imagine anybody did. When the suggestion came up, the Haemophiliac Society was ferociously against any idea that you stopped people taking imported factor VIII. And had we banned taking imported factor VIII, we'd have been faced campaigns as vehement as the ones we do now, but on the other side, saying, what were we doing? Destroying the life expectancy and the quality of life of haemophiliacs. Because at that stage, there were very, very few cases of anybody actually dying.
Would you accept as a matter of principle, and as this recommendation appears to suggest, that the patient deciding whether to
yes,
treat
you should tell the patient of the risks of treatment.
Their child. They should be told the risks of treatment.
And that seems that was true then. It's the best practice of medicine. It's much stronger now. When you're having treatment now, you get carefully to the patient consent involves carefully explaining all the risks. That was a very good principle in the 1980s. It wasn't always followed, so they'd often operate on the patient without bothering to tell the patient what the risks were of the operation. And nowadays, if you ever are unlucky enough to need an operation, you'll find you're carefully taken through it and asked to consent. But the way in which you tell the patient of the risks, you have to be, there's no point in just terrifying them without being able to suggest anything you can do. So, yes, it would, in principle, the physician should have been discussing with the patient, there's a risk. There appears to be some concern that it's possible. You might be infected, we just don't know.
You indicated in an earlier answer that there was material out there in the media, and I think you used the phrase about being switched on. Apologies if I haven't quite accurately repeated what you said. Would you accept that it shouldn't be for patients taking decisions about their own treatment or taking decisions about the treatment of their children to learn about risks from the Mail on Sunday rather than look to either their clinician, sorry, can I just finish the question?
Sure.
Look to either their clinician or to the department and the chief medical
Well, it's the clinician. The person who's responsible, the department has no say in the treatment that the clinician gives to his or her patient. Similarly, it is the duty of informing the patient of any risks falls on the clinician. And that is true today, and clinicians take it more seriously. One reason is because we've got ever more litigious in the previous years, so warnings about risks now become copious because the lawyers will advise the doctors the way of making sure they're not held legally liable if the treatment doesn't work is to explain these risks carefully before you do it and get genuine, fully informed consent. In the 80s, it wasn't quite like that. But the duty is on the physician, firstly to decide what treatment, secondly to order the risks. And I'm not saying this, shove it all onto doctors. That is part of I have the highest regard for doctors, and that is one of their very, very heavy burdens of responsibility that they carry as they act in the best interest of their patients giving treatment.
But this was a recommendation accepted by the department that governments of member states should inform haemophiliacs of the potential health hazards of haemotherapy. The department should have done something, should it not?
What should the department have done?
Issue guidance, issue information, ascertain what information was being provided by haemophilia clinicians through the UK HCDO to patients.
Well, I don't think the doctors treating haemophiliacs would need that guidance. It would be bizarre if a haemophiliac specialist, I mean, we've taken me through all these subcommittees of expert, all the rest of it. There was a perfectly live debate. As it happens, it got into the general newspapers.
Does it?
And the haemophiliac patients, what do you sort of post a leaflet to them all?
Does it not trouble you then that the department took apparently no action to comply with this recommendation?
Obviously Simon and I signed up because we were trying to avoid the use of these. The first one, we were trying to get self-sufficiency in production, and the third one, we were trying to stop at-risk groups donating. Obviously, the second one's harmless, but now I think that when we got a message and just said, yes, we agree the recommendations, we were not agreeing it in detail. And in detail, of course, when you say, well, what's the department to do, it is difficult to say, well, what should the department have done?
Let's look at the second aspect of it then, which is...
Not least because there was no certainty about what the full potential health hazards were.
If we look at the second limb of the information to be provided under this recommendation, information about the possibilities of minimising these risks.
I'm not sure what they were.
Well, that's exactly what I'm going to try and explain.
Did the Council of Europe have any suggestions as to what they might be?
Not to my knowledge, no.
No. I don't think anybody did.
Well, what did you think at the time, Lord Clarke, were the risks to haemophiliacs if imported concentrates were not available or reduced supplies were available? Well,
you asked me at the time. I do my best at the time. I mean, none of us can avoid the wisdom of hindsight, and actually preparing for this committee. Once you start bombarded with thousands of documents, and then I start with the help of DH lawyers working through the answers to all your questions, so being shown masses of documents, some majority of which I've not seen before, a certain amount of amateur, not expertise, but my knowledge of the whole subject is hugely improved. And of course, hindsight, I have knowledge of the terrible tragedy that eventually occurred when people started dying in large numbers from taking from polluted air. So looking back, the issues were that did seem to be there was a worry. It was worrying from the word go that we were so dependent on imported blood products from America. And we quite early discovered that there was no alternative supply that could provide us with sufficient quantity. So the decision had been taken, it was finally taken, I think, just after I arrived in the department, to go for self-sufficiency, which involved rebuilding or doing major work at the blood products laboratory at Elstree. So we wanted to be self-sufficient, produce our own. But it was worrying that there was a risk, and then we started having these quite few cases, but they were disturbing because haemophiliacs who'd taken American factor VIII were indeed getting AIDS, maybe just 2 or 3 of them. Now, of course, we had no idea to what extent our American replies were polluted, were contaminated. Were we just every now and again, every 6 months, the odd batch would turn up and, which really shouldn't be given because it's contaminated, or was a lot of it contaminated? Was it? No one had a clue. Was it the case that this was causing the disease? Well, it did look, certainly was a possibility. It looked as though it might be quite probable, but no doubt you'll get on later. There was no conclusive evidence that it was causing it, and it may be, this was the problem with new diseases. More research presumably was going on to actually try and see what it was. So it was difficult to inform the world of this because there was no certainty about it, and also there was no ready solution. The only solution we were then aware of, that I was aware of, was this go for self-sufficiency, and that involved improving our British blood donations, although we didn't have the same problem. The solution eventually was heat treatment, but that's what solved it all. But I knew nothing about heat treatment. That was a matter of some brilliant scientist somewhere discovered that heat treatment stopped anybody being affected with hepatitis or HIV, and we now take blood donations in this country from homosexuals because you heat treat it and it can't infect anybody.
My question was not what would happen to haemophiliacs if they carried on taking imported.
But at this time,
my question
there's nothing really you could say to anybody.
No, my question is this: what did you think the risks were to haemophiliacs if they didn't have access to factor VIII concentrates?
Well, you better ask a doctor what the risks are. You've had to take a lot of medical office. My lay understanding, and I don't know whether I had it at the time or whether I quite know. I think I did have it at the time. It was explained to me because what's the factor VIII for? I can't be amazed if that didn't come up at some stage. My understanding, though I wasn't remotely involved in the 70s, I have no idea what went on in the 70s. The impression I think I had at the time, the impression I have now, is that there was a kind of wonder treatment that had emerged in the late 1970s for haemophiliacs. Before that, the life expectancy of haemophiliacs was very poor. A lot of them died off in their 20s. The ability of a haemophiliac to lead an ordinary life was very, very limited because they had to avoid risk of bleeding incidents. And factor VIII was a kind of wonder product, particularly once it started being used, way before, in the late 70s again, as a prophylactic, a preventative medicine. And if you took it regularly as a prophylactic, haemophiliacs lived longer, they could lead an ordinary life. If they were schoolboys, they could play football. More importantly, if they were adults, they could start having a job and a career and leading, as long as they were careful. Unfortunately, it's a terrible, terrible condition. Of course, the lives of haemophiliacs all blighted by this condition. But they would live much nearer a normal life, have a much improved quality of life, and on average, live very much longer if they took factor VIII. That is what I think factor VIII was. But unfortunately, when these doubts arose, when people discovered the American practice of taking blood donations, there was no alternative source of supply that could meet the demand we now had for factor VIII once the doctors were starting to prescribe it as a prophylactic.
You've said, I think, on a number of occasions.
But anyway, I'm going around on much bigger, wider subjects, which I think are the point of this inquiry, and which the inquiry will go into and form its views on. But that you did ask me what's the background to what could we actually have done by way of informing people with haemophilia of the possibility of minimising risks.
You've referred on, I think, more than one occasion in the course of your evidence to your understanding that without concentrates, haemophiliacs would have died. Is that right? That was your
Their life expectancy is greatly improved. I mean, don't just drop dead through not taking it. But I think, but I tell you, I'm not a clinician, so if I'm wrong, I'm wrong. I'm sorry. I'm sure nobody's going to take any notice of my clinical opinions if I'm unwise enough to express any. I'm saying my understanding was that the life expectancy of haemophiliacs was greatly improved. It was believed at the time, wasn't it? I think I've no reason to doubt it. I think it's still true now. Their life expectancy was improved if they were given factor VIII as both as a treatment, but by the early 80s it started being used as a prophylactic.
And do we correctly understand from something you said earlier that you were not aware of a treatment called cryoprecipitate?
Never heard of it. Is that the treatment that preceded factor VIII?
Preceded and continued.
Sorry?
Preceded, but also continued to be used to some extent.
Continues to use today, is it?
No, continued to be used during the period of time with which we're concerned. Continued to be used during the period of time which I'm asking you about.
I don't think I've ever heard of it. I mean, I've seen. I think I saw looking at the documents yesterday, reference to it, but I have no idea what that is.
Were you aware that haemophiliacs could not all simply be lumped together as suffering an identical condition, but there were ranges of severity, mild, moderate and severe, with different treatments?
I was vaguely aware of that, yeah.
There are potentially a number of measures which might have been taken. I'm just going to list a handful of them and see whether any of them are ones which you recall being discussed at the time, Lord Clarke. So one was reversion of use to cryoprecipitate to a greater extent.
I have no recollection of that ever being put to me. I don't know what that treatment is. I've only heard of it being referred here.
Reducing the amount of concentrates which were provided to an individual patient by, for example, not treating them prophylactically, not having home treatment, but treating the severe bleeds.
So treating bleeding incidents, yeah.
Yes, or treating life-threatening bleeding instances, for example, but not treating all bleeding. So that's another measure.
That's the equivalent of stopping taking it, except when you have a severe life-threatening situation.
Postponing elective surgery so as to reduce the need to have concentrates at least temporarily. That's another measure that could have been taken.
Sorry, this is for haemophiliacs that need elective surgery. I don't remember that. I suppose that is right. But
reserving, limiting exposure to multiple batches of concentrates by keeping haemophiliacs on an individual patient on only one batch or one type of concentrate. That's a measure that might reduce risk, not eliminate it. Was that something that was ever ventilated? Mm-hmm. Do you recall any discussion of the use of a treatment called DDAVP or desmopressin?
Called what?
DDAVP was a treatment that could be used for mild haemophiliacs from the late 70s onwards. Did you, or to your knowledge, the department, ever ask officials to investigate what other steps could possibly be taken short of the radical step of stopping the importation of concentrates?
Well, I think we were told that was the only thing you could do. That's why everybody had gone so big on self-sufficiency. The solution was to stop needing American factor VIII. I don't remember anybody ever raising anything other than that, or stop using it for fully or partially, as you say. Now, I don't remember any halfway houses would have been interesting, but I don't remember. I was certainly, again, because bear in mind, I was not directly responsible anyway. I don't know whether Simon ever was taken through possible alternatives or what the doctors have said when you put the possible alternatives to them. But My understanding was that there was this mounting concern about the possibility, even becoming the probability, it was causing this problem to a few haemophiliacs, and the only solution was to stop using factor VIII, that you couldn't do that because of the drastic effect it would have on the quality of life of haemophiliacs, and that, just get on as quickly as we can in minimising our reliance on the imported product. These other things you're suggesting, certainly I didn't have any discussion of that kind, but I didn't have meetings on blood products and haemophiliacs, and it wasn't my subject, and they wouldn't have come to me anyway in the first place.
Leaving aside the question of who should have asked the question, do you accept that the department should have investigated whether there were alternative measures?
Well, I think that's better on. These are clinical issues, and the clinical solutions to the problems we're concerned. I'd say that the one thing about ministers in the Department of Health is they're not meant to play amateur doctors. So the subcommittee of the biological, whatever it was, that's the sort of place where you look at those things. And if you then come up with recommendations, eventually, you go up to some minister to get it signed off, but the chances are the minister's not going to argue with the expert clinical advice. That's where these things are handled. And the medical officers in the department, their life is devoted to these things. If they have bright ideas about how to deal with some clinical problem, yes, they discuss it and see if they all agree, and whether they should put out some information letter or something suggesting this, but that's where it's all handled. But the idea that ministers are meant to sit down, sit down and start devising alternative ways of dealing with it is unlikely. And what you're asking me is, was it ever raised? No, it wasn't raised, but you may be going on to ask me, am I surprised it wasn't raised with me? Not greatly, because it's not something that essentially is within the expertise or responsibility of ministers to come up with these clinical answers to things.
My question was not whether you as a minister should have investigated whether there were alternative measures, other ways of reducing risk, short of the radical solution or the more radical solution of banning imported concentrates.
Well, my question was whether... What did Diana Walford say?
Well, you're very welcome to read the transcript of her evidence, Lord Clarke. It's published on the Inquiry's website. My question to you is the question of principle. Do you think, as someone who has led many government departments over the years, including the Department of Health, do you accept that the department, through whatever means, the chief medical officer, medical officers, health services branch, whoever, junior ministers, whoever it might be, should have inquired into the question of whether there were measures that could be taken, short of banning imports, to reduce the risk?
No, I'm sure they did. I mean, but the impression I received as a minister, admittedly a peripheral minister who was only getting involved when he chose to get involved in things like leaflets, the impression I had was that the only way of guarding against this mounting concern about possible risk was to stop using factor VIII, and that would involve stopping giving it because we had no alternative supply for about half our supplies to American imports. And I was but I mean, somewhere in the department, they must have considered whether there was some halfway house, I'd have thought, I don't know. And no doubt you will ask and have asked the medics whether they did and what happened to it.
Just two documents before we finish for the day, Lord Clarke.
We're finishing for the day.
Before we finish for the day, two documents I want to ask you to look at. The first is at ITVN 00000041. This is an exchange of communications between you and the producers.
Oh, I've seen this yesterday.
Yes,
Yeah.
The producers of a documentary. And if we could go to the third page, just wanted to ask you, for present purposes, about one of the things you said in your response to the producer. So page 3 of this. We've only got 2 pages. Oh, sorry. It'll be a separate number. ITVN 5045. Sorry. So this was your response, and I just want to ask you about the third paragraph, which begins, I did not ever attend. So you say this, I did not ever attend any full policy discussions on the question of blood products for the treatment of haemophilia, although I was aware that there was a discussion going on the subject. And then you say these events are over 30 years ago. I have no recollection of ever being shown or told of the opinion of the Communicable Disease Surveillance Centre. I think that's a reference to the letter from Dr. Spence Galbraith.
Oh, that's Dr. Galbraith's letter,
It is.
Yep.
In clinical issues of this kind, all ministers rely heavily on the advice of the chief medical officer and the medical and scientific experts in the department. So that was what you said there.
That's what I've been saying all day.
I wanted to ask you about what you mean in the first sentence where you say, I did not ever attend any full policy discussions, although you were aware there was a discussion going on the subject. What do you mean by full policy discussions on the question of blood products?
The kind of policy discussions I had on other subjects, pay claims, strikes, hospital closures, whatever,